just call you and kick us off?
Sure, if you want.
Okay.
Good morning. Hello. Hi, everyone. Good morning. Say it back. Good morning. My name is Michael Ligodaro, as you probably know by now. Some of you have taken my T-shirts already, so thank you. I'm with Prevention Access Campaign. I'm our Global Director for Policy and Advocacy, so good to be here and to be with you all, and thank you for joining us. And sorry for the late start, but we're going to kick off now. And I'm going to welcome our hosts and also the President of IPAC, Jose. Jose, please.
Thank you very much, and good morning to all of you. Sadly, at these types of conferences, there are competing events constantly. Right next door is an event on stigma indicators and implementing them across the Fast Track Cities network. U equals U is part of that session too, but it happens. But thank you again for joining us at Fast Track Cities 2022. We're excited about having this U equals U symposium as part of the conference. As most of you know, U equals U was integrated into the Paris Declaration on Fast Track Cities Ending HIV several years ago. And through that, many cities and municipalities around the world have either introduced or scaled up U equals U, I equals I, K equals K type of activities. We're proud of those, but obviously those need to be scaled up because we're not at the point, I believe, in any city or municipality of the world where U equals U has really taken root to the degree that it needs to. We're still sadly confronting significant pushback from the medical community, and it's something we need to address firmly. We are committed as IPAC, a professional medical association of 30,000 clinicians, to make sure that our clinician membership is communicating U equals U message, and in that way destigmatizing HIV diagnosis and, it's important, people living with HIV. But additionally and beyond that, just yesterday, we launched the Sevilla Declaration on the centrality of affected communities in the urban HIV response. We had mayors, deputy governors, representatives from multiple countries around the world sign this declaration just last night. And central to this declaration is the importance of defining and facilitating how you place communities at the center of the HIV response. Something that was not very clearly communicated in the Paris Declaration is now. And our task ahead is to make sure that that declaration is equally enforced across the Fast Track Cities network. The good news about the Sevilla Declaration is that there are at least 8 out of the 10 commitments in the Sevilla Declaration that are relevant to U equals U. And so we'll be working with Prevention Access Campaign and other partners so that as we start planning for the implementation of this new declaration, U equals U factors very prominently within the context of the work we advance. I want to thank you again, Bruce, Michael, thank you, all of you, for your hard work as U equals U warriors. We're very supportive of your efforts, as you know. Count on us, let us know what we can do. Very obviously, with respect to the Fast Track Cities initiative, UNAIDS, our partners in this endeavor, are hugely supportive of you. Let us know what we can do. Thank you very much and have a great symposium.
Thank you so much, Jose. Thank you for providing this space for us and for your support to PAC and all the work that you all guys do. Amazing conference. I'm going to move over now to my boss and colleague, Bruce Richmond, who is the founder and executive director of Prevention Access Campaign. Bruce?
Thank you so much, Michael. Awesome, and thank you so much, Jose, and the folks at IPAC who've been pioneers and leaders in this campaign since very, very early on. I'm going to go really quickly through this in the interest of time, and also because so many people know what U equals U is, I'm also going to just do a karaoke session really quickly, if that's okay. So what is U equals U? I think everyone knows what it means, but the main thing is that this just didn't happen overnight. This was a really assertive, sometimes aggressive collaboration between researchers, advocates, public health officials, community organizations to first build a consensus around U equals U. Bring the scientists together to confirm that this is true and make sure that the leading agencies in the world were saying this. It's done. We did number 1, thanks to so many of you in this room. Now we're really still working on 2 and 3, disseminating, but number 3 is really what we're talking about, is advocacy, making sure that people everywhere have access to treatment and care to stay healthy and prevent new transmissions, which is now what we can prove. And preventing new transmissions is the key to ending the epidemic, saving healthcare costs, and we're going to be talking about that a lot today. Now PAC's leadership structure is really exciting. We have a very high level, sort of, the PEPFAR, the Gates, the Gilead, ViiV, CDC Global, UN AIDS are a part of this global collaborative, the organizations that can influence governments to change policies and laws and access to treatment and care. And we also have a really important global community leadership of activists from all over the world who are connected on a community level. These 2 bodies can work together to make tremendous change. And so we're really excited about how this is coming up in the next couple years. So we always want to remind people of why U equals U is important. It's important for stigma, but it's important for so much more. First, our quality of life for people with HIV. We can have sex, we can conceive children, we can date, we can marry, all these sort of things without fear. People are calling their babies U equals U babies. They're tattooing U equals U on their bodies. They're rising up all over the world because of how this is changing our lives. This is also reducing stigma. That's a big obvious one. Stigma is one of the greatest challenges to ending the epidemic. And U equals U is an immediate and effective response. It also is clearly propelling us towards our 95-95 goals. 95, 95, 95, I got all 3. And because first, there's data that shows that when people with when HIV negative people are aware of U equals U, they're more likely to get tested. There's a study in South Africa that showed that men who were HIV negative were almost 2 times more likely to get tested for HIV when they knew U equals U. This also is another incentive to stay on care and to stay in treatment and to get virally suppressed, to stay healthy and not pass on HIV to our partners. Also, in terms of ending discriminatory laws, practices, and policies, we're seeing tremendous progress around non-disclosure laws and transmission of HIV and marriage license, educational opportunities, immigration status, employment, healthcare, changes all around the world because of this new science. There's a lot of work to do in this area, though, a lot of work to do in policy. And then finally, this is really what we're talking about today, or actually these last 2 is calling for universal access, calling for health equity. This is a clarion call for that. We're in a good place to do this with this massive movement. It's not well known as a movement, and that's partly my fault because we haven't really publicized it well, but it's in 105 countries now, completely community-led. We also have partners at the highest level to work together to change this. And what are we changing? It's the identification of U equals U, of getting people healthy is the key to end that epidemic. Getting people with HIV healthy is the key. Ensuring that we have what we need to stay healthy, whether it's treatment, whether it's services, peer outreach programs, housing, all kinds of things that keep us healthy and undetectable is great for public health. It's essential for public health. So we need to use this in our advocacy. This is what's called the win-win strategy. And our goal is, again, health equity for all people living with HIV. It's an incredible time for us because now, again, keeping us healthy, when we're advocating for all these things to keep us healthy, it's good for everyone. It's, it's Ubuntu, it's, kumbaya, it's, we're all connected. It's a really great feeling. So now I'm going to move it to Michael. Actually, I'll go through this really, really quickly. You're going to do this? I'll do this. Okay, so the main thing is, looking at this is good for individual and public health. This is good for the economies of country. This is good for on societal level. So all the different benefits of U equals U, in addition to our right to health care, in addition to calling for ending inequalities, in addition to our personal health, this is good for everyone. So now I'm going to bring back my incredible colleague, Michael, to talk about what do we need governments to do and go a little bit further with what the win-win strategy is. Thank you so much. Okay.
Thank you, Bruce. Again, really quickly, I know you all have came to the booth this week and asked us what is win-win strategy, how do you want to get involved, and how can you actually get your government to get on board. This is essentially what we hope that folks can get on board with, and this the hard work comes to play, because again, it's great when countries sign on. It's important when they adopt the policy. It's great when we get the campaign going in your countries, but actually this is the implementation plan. Like, we want your government to sort of integrate official government policies, like change the laws that make people not access treatment, change the laws that make it difficult for people not to understand treatment literacy. So change those laws on the ground that makes that impact people for getting access to treatment. That is key. But also, like, increase access to treatment, care, services, all of the structural issues that we all know about in our countries. Yes, a lot of people can get to undetectable viral load, but some people cannot. And why can they not get undetectable viral load? There are structural issues, there are structural barriers. That's why it's so important that we look at our policies, look at our government issues, and make sure that community come together to make our government not just stand on board and say, yes, we've signed on board, you because it's there, but how do you actually implement it? What are the things you need to change to make sure people get to the first U before we can get to the second U? That's really key. But also educate. Education is really important as well. And some of you, people know U equals in general terms, but actually, how do they actually implement it in hospitals, in healthcare centers? Those nurses, how do you make them change their mindset about what actually U equals U means? And that it's not just about stigma reduction, it's actually a very effective prevention option. When you think about PrEP, you think about, condom, think about U equals U as well. It's not just about stigma reduction. Actually, like, if people get on treatment, if they achieve undetectable viral load, that means there will be low risk of infection. When I mean low risk, there will be like no risk of infections, because HIV is not coming from the hair, right? Where's HIV coming from? If you can get people on treatment, it means they achieve viral suppression. They are unable to transmit new infections. So effectively, we are reducing the new infections rate in different countries. That's really key and important. So that's why we have to educate our government and promote UECOG clearly, get the messages out. So what we are doing at PAC this year and moving forward is make sure communities on the ground understand how to use the concept, how to use data, use your own community data. There's no other effective tool you can use to make your government change their policies down your own tool and down your own data in your country. Get the treatment data in your country. Get how your government are investing in treatment literacy. How much are they investing in promoting literacy around effective use of treatment? So get those data and use them as a tool to move them to do things better. So this is the win-win agenda. So right now we have over 50 organizations from across the world who have signed on to this agenda. We're looking for more partners to get on board. We have a plan to get people on board, but I think this is essentially what we're going to do. Building power and influence via the win-win agenda with civil society. CSOs are key as center to our strategy. We cannot get this on board. We cannot make these changes without CSOs in country, right? Like in country where the advocacy happens is where we are moving to. Using data, right? We do campaigns, we do education, but actually what we're trying to move into is how do we use your own country data and train people on data use. Understanding data is complex, right? We need to understand how many people are on treatment in your country, how many of them are virally suppressed, why are they not virally suppressed, how do you get your government to change issues in your country. Using data is really, really key. Again, we are moving towards a very data-informed strategy at PARC. Also ongoing, learning and evaluation, right? I think impact is really key. So our strategy is going to be based on impact, right? We're going to be monitoring how much impact are we making in each country. If we're working in Zimbabwe or in Thailand or in Malawi, how much impact are we making? How many people are getting no treatment? How many of them are getting virally suppressed? Who is making those changes? Who are those key organizations on the ground, community-based organizations who are making those changes? And how much impact are they having? We all love campaign. We all love work plans that go on forever. But at PAC, with this agenda, we're going to be a very strategic work plan with our partners to say, if you're going to change just one policy or two policies, how long is it make it to change it? Is it 6 months? Is it 1 month? Is it 1 year? And track the impacts you're making every single step of the way and learn from those impacts. Also advocacy, there's no success without advocacy, right? Advocates make the changes. PLHIV advocates have made the changes in this field for the last decade. And we want to make sure we're going to rely on them to make these changes moving forward. Right, like I said earlier, we have partners who have signed on board. Again, this is a new iteration of U equals U. This is not just a campaign anymore. It's actually campaign and advocacy and strategic advocacy on the ground, relying on advocates on the ground to make those changes in their own country and providing them the resources they need. PLHIV, women, key populations, trans people, empowering them to have their own government to make the change that they want in their country so that people living with HIV can also all people living with HIV can have access to treatment. We all know it's very difficult for most people. Like we have, treatment stock out. We have, ARV stock out. We have, policies that hinder transfer of, treatment. How do we identify those key structural issues and work on them? Because we know our government will listen to, if we tell them, if we make the economy sort of argument with them, say, hey, if you get more people on treatment, if they achieve viral suppression, there will be less people who are going to get on treatment because there will be no new infections. So it's actually an economic gain for you as well. It's not just for us a stigma reduction strategy. Actually, it's actually also good for you to save you more money to invest in PLHIV, to get more people on treatment so they can achieve viral suppression, so that there will be less new infections. It's as simple as that. So, right, how do we make sure we all do that together? So our partners are from Africa, from the Caribbean, from across the world. We are doing the South-South, South-North coalition building and getting partners who are key and important in this field to come together. IPAC is one of them. GATE is one of them, obviously, Prevention Access Campaign, and others as well. So we're really excited about this new iteration of U equals U. We had our first, those of you that were, how many of you were at the IAS? Were you at IAS? At the IAS conference? Yeah, so we had this amazing sort of launch of U equals U, but also a protest, right? Sort of let the government, let the policymakers know that we are the key to ending the epidemic, right? If you invest in PLHIV, if you invest in us, we can actually effectively end HIV. It's as simple as that. If you get us care, if you eradicate the structural issues, the barriers that hinder people getting no treatment, there will be no new infections. That's the strategy we are moving towards. I think that's really key. In addition to PrEP, in addition to condoms, in addition to other prevention options, U equals just as key, even more important than all of those above. Right, and there's a video here I wanted to play with you guys, obviously from, how do you play this? Can you help me? Sorry, that's great.
That instead of draining society in the sense of healthcare costs, that it will be actually putting into the economy of society. At the same time, by those individuals having an undetectable viral load, it is one of the most powerful ways to prevent the transmission of infection and keep other people from winding up living with HIV. I think when the history of great public health accomplishments are going to be written, I'll guarantee you, it may not be universally accepted now, but U equals U is going to be right up there.
Yeah, I think it's a win-win. I think it always has been. We've always felt that if people who are infected are on treatment, it's, as you recall from the very early days, or even just 10 years ago, treatment as prevention. Treatment reduces the virus in your blood. It can be prevention. It can be life-saving. It's both at the same time. So once somebody is on treatment for a lifetime, it allows them to live their life as they would have wanted without HIV. So I think that's important. And it's also about protecting partners and protecting those you love, and having virus in the blood are undetectable through the tests being used means that one can have that life with the partners, with your family members, etc., that one would like to have. So I think it's always been there, and I think it also can encourage people to commit to staying on therapy for life. That's also a really win-win out of that.
Completely. It's a great, it's such an amazing movement, and that's why UNAIDS is so proud to officially endorse, stand behind U equals U. And actually, U equals U is even mentioned in the high-level meeting political declaration for the first time. We've got the Geneva UN declaration adopted and negotiated by member states of the General Assembly. So it's not only something that we were inspired by and fully supportive of, it's actually our marching orders to the entire UN system and for all member states. They need to be implemented U equals U. They need to be celebrated, trumpeted, and advocated about it, because we can spend billions of dollars on really expensive programs and really complicated health systems and mobilizing millions of tablets and injections is the quality of life and the contribution it makes to fight stigma and discrimination related to people with HIV. But U equals U also has a profound positive epidemiological impact. Because people living with HIV who know their status, who are on treatment, who have undetectable viral loads, can be absolutely certain, unquestionable. The science is clear and has been clear for years. Someone who is undetectable and still remains HIV positive or living with HIV cannot sexually transmit HIV to the sexual partner, even if they're not. So the science is clear. It's part of the official WHO, UNAIDS, Tony Fauci endorsed National Institutes of Health, U.S. domestic HIV strategy. It's the best of HIV science. And now our challenge is to make sure that all almost 10 million people living with HIV that still are not on life-saving antiretroviral treatment immediately from the science, immediately get access to the best of antiretroviral medications, and also can benefit from new people soon.
There's a win for everybody. It's a win for society, it's a win for funders, it's a win-win. I mean, how about this 30, 40, 100 different ways. But you could use an example of something that it took, it has like too long for that scientifically proven message to become embedded. And I think there's still too many limitations for people living with HIV. In the UK, you have successful changes from the Civil Aviation Authority, with the Ministry of Defence, around treating people with HIV like people. And U equals U, I think, is absolutely essential.
It is a win-win because it's more than a win, it's a win-win. It's a win first because the people are expressed, they're not contained to their native partners. That's it. Two, if your virus is you can be healthy, you're going to feel good, you're going to live a absolutely normal lifestyle. That's it. Three, it's a win because it changes the perception and the dialogue around HIV. And we don't have a cure, and we don't have a vaccine at this point, but we have this, and we know that this is incredibly powerful. It's not the full answer, PrEP and other things, but it's a game changer.
It's absolutely a win-win. I mean, there is no use for that, right? If we can make it universally accessible, if we can take away the barriers that certain populations face in accessing those services, then it's wonderful. It means that people living with HIV have a much improved quality of life, much less stress when it comes around thoughts of having sex with people, like the fear of infecting somebody else, and for people who aren't infected, but in a committed relationship with somebody, knowing that's just not an issue anymore. So I think, as I say, we've got to put the structures in place now. I think, to me, the HIV response now has to move out of the clinic even more than it has already. There's a whole economic aspect to it as well. That isn't just even about a single country, but it's global. And if we're spending fewer resources on treatment because we have fewer people becoming infected, because we have so many people who are undetectable, that is more resources to put into the other stuff, like changing bad laws and addressing discrimination. So I think it's kind of like a win-win, where there's the micro level benefits and as well as the macro.
It's an absolute win-win. So I think the message needs to get out there that if you're on treatment, you can live a full and healthy life. So I think that's what it means.
I know losers with you was you. And I think we embrace that and we live that. Our program documents that. You can just tell with the student success we have that there's you equals you is the way forward.
Win-win is common sense. When people with HIV have what we need to stay healthy, the treatment, care, services, we not only can live a full life, but we don't transmit HIV. That's a win for us. That's a win for public health. It's the way to end the epidemic. So now we know investing in our health is everything. It's our time.
It's just like black and white. Keep us on treatment, we end HIV. That's it. Keep us on treatment, we end HIV. Give us access, give us care. Let us have the benefit of the lifestyle that we want to have, that we desire for our lives, for our partners, and we will end HIV because, like I said, the virus is looking from the air. There's something from somewhere. If you can contain it, not easy, but contain it. You can keep people with that safe, and they can achieve you because the virus will not spread anywhere, so literally that's it.
How many of you hate watching yourself? I hate watching myself on camera. I cannot stand myself watching. But thank you all. This is exciting. We're really proud about this video at the AIDS conference, and you've heard it. Nobody can say it better than Tony Fauci. So it's like so important that we take this lesson and take to our community. Because of time, I'm going to hand over to our very esteemed keynote speaker, the Deputy Executive Director of UNAIDS, Eamon Murphy.
I thought this panel was for us to sit at some stage. Now, much of what I've got in my speech has actually been touched on by the previous speakers, but I think a point that Bruce made is critical, that we affirm it clearly and loudly from the partners that are supportive and convinced, right? Science tells us, right? And I've got the studies in front of me that have confirmed this, and we've heard it just now from Tony Fauci speaking on behalf of CDC, US, WHO, we saw Meg, UNAIDS, it's all clear. Yet, we know that there are times that some of the most respected clinicians working on HIV for many years have been challenged by this, by other clinicians. Often it's a issue of inequalities, it's a power dynamic, it's an understanding of the partnership that's evolved in this relationship of people living with HIV with care providers. I always remember taking a very senior US official to meet doctors and visit a clinic in Burma, Myanmar. And he asked the head doctor in this hospital, what's the most difficult thing for you in HIV? Now, we saw very poor facilities, very basic. Supply of drugs was a problem, you can name it, right? The first thing she said to him was, my problem is that the patients know more than some of my doctors, right? That, to me, was the power of what we see in this whole dynamic, and it changes the dynamic, and others in public health don't always benefit from. But this is part of the issue with U equals U. We need to get that message out there, the dissemination that's in the roadmap. We need to disseminate the information to all levels. Community, clinicians, public health professionals, the administrators, the policymakers, the politicians all need to understand the win-win-win-win, as Laura, and I'm not going to say as many as Laura Waters said, but there are so many different facets to this. And I'm going to repeat a couple of them, and I won't apologize for that, because I think it's important that as an organization like UNAIDS is also endorsing a number of these areas and confirming them from our perspective. So we heard already about the definition, so I don't need to go through that. But the critical issue, I've been working in HIV for more than 25 years, starting in Australia, working in countries throughout Asia Pacific. One of the hardest things to overcome is the self-stigma that people face, right? Now, I've been talking to people who are living with HIV but afraid to tell their families, certainly afraid to tell their employers. One country I worked, taxi drivers had to be tested for HIV every year to renew their license. I'm not sure what the stats are on how many transmissions came from taxi drivers, but you can imagine. There was a major reform in one country, but they left pilots needed to be tested for HIV. Again, some weird science behind some of these things that's still stuck in the systems all over the world, you know, and some of the most advanced medical systems are in these countries. It's not the assumption of other countries who aren't as informed about this. So we've got a long way to go to get the science better understood. So this is important. Self-stigma, though, is critical, because if you're willing to take that step forward, knowing that getting tested, and many don't get tested when they already know themselves that they're unwell for a whole range of reasons, societal reactions, employment risk, family. But this is such a power changer. If they can get on the treatment that is available now in so many places. Earlier days, very different scenario. But the other thing with this is the viral suppression. And I find it difficult when I hear terms like from clinicians and others, someone is virally suppressed. No, the person is not virally suppressed. The person has achieved viral suppression. They are in control. That's another win out of U equals U. They are in control of this virus in their body. That gives them power. It also motivates them for why do they want to take treatment? Why do they want to maintain it? Treatments are getting so much easier and going to get easier again. We need to make sure we've got the best available treatments out there. We talk about the inequalities. One of the challenges, I was talking to one of the delegates here who was talking about migrants after the panel yesterday, and was saying in their country, if you're a national and living with HIV, you get the full treatment options, all support free of charge. If you're a migrant, you get a regimen that's not available in the public to citizens of that country. So what's that saying? That's about the discrimination. U equals U can change that dynamic as well, if that's understood then about why there's the economic benefit to the community these people are providing through working in society. And these are long-term migrants, not transitory migrants or anything else in this country. So it's about power dynamics, about the inequities, the inequalities. So there's the individual, but we've got to get, as Bruce was touching on, that economic question. The benefit of changing this dynamic of getting people on treatment, but then stopping further transmission is critical to the agenda that needs to be there. So win-win-win, we certainly do not see losers in this whole agenda of U equals U, and that's why we are so strongly behind it. As you heard from my colleague, it's in the political declaration. Now, the political declaration last year is critically different to usual because the member states, the countries around the world, actually had to vote on it. Right? I'm so old, I was there in 2001 as part of a country delegation, and we voted on it. And that was a major fight to get even little words in. The process keeps going every 5 years, but normally it's just passively passed through the system. This time round, because of politics, it needed to go to a vote. The changes in it were critical. There were issues of stigma and discrimination, targets that countries are going to work for. Cities will have to be addressing these. U equals U in it is a critical part of that agenda. And so that's why it's so important. A global AIDS strategy is put out by collective partners through UNAIDS, but that doesn't have the power of enforcement that the political declaration does. So for those of you advocating, please refer to the political declaration. That's going to be critical for us. So there's still a lot of hurdles, as we said. We've got to get this information out there. There are so many new opportunities, and COVID has increased the opportunities. Differentiated service delivery. We've seen countries change. Rather than the client having to come into a fixed site medical facility, now drugs are delivered to home, be that PrEP, be that ARV, even OST for people who are using drugs. Treatment delivered and kept at home rather than having to visit a centre every day. So there's a whole range, WHO, a whole range of new guidelines. I'm not going to go through the detail of all of this today, but just a couple of examples. The provider-initiated testing, the index, the self-testing, another critical change. There's still so much stigma in society and risk of employment and other losses to people that self-testing, testing yourself at home, being that online with a support, that gives you power again. This is about the issue of inequities and power imbalance in society. So that's a critical new tool, and yet not widely available. Again, systems like to keep knowledge and understanding, and so they want to do the testing. But we're seeing that breakthrough in many countries as big as India, where you can now get self-testing less than $1. So we're not talking about significant cost, and it gets cheaper all the time and easier. There's a whole range of others, the adherence clubs, the mobile technology now to make things so much easier for people. But what we will need are the cities to get behind this. The cities are going to be critical for this because we need some changes. We need good planning to make sure that the systems are out there so people can rely on the system for the access to the healthcare needs that will supply. So the supply chain, the management to make the commodities consistently available, no stockouts. You know, we recently saw stockouts in India, the world's largest manufacturer of ARV medicines. Now, if they can't get the stockout system challenged, that means the cities have to be involved in this, not keep it at the national level. That's why the Fast Track Cities initiative is so important for us. the enabling environment. The critical changes are policy and political. And that's why this movement of both communities as well as the decision makers have to come together behind this. Cities are a powerful force for change. We saw with the Seville Declaration, for those who saw them yesterday, the power of the city here with the state and the federal governments. These all have to be used as part of the agenda. So treatment access to end the inequalities I touched on with the migrants, refugees. Everyone needs to be equally accessing if we want 95 targets. The goal for all of us is to see HIV in a whole different way in society. It will be with us forever, even when it's not a public health threat. But it's not the HIV that we were dealing with at the beginning of the epidemic, and it's significant. Part of that change as we move forward will be U equals U. The roadmap is there. So let me come to the conclusion with focusing on the area that is most important. We need the cities because that's where the the concentration of population is becoming greater and greater day by day globally. Cities have to be at the forefront in mobilizing their communities, the healthcare workers, clinicians, technicians, researchers, entrepreneurs, and the officials and development partners. Challenge the system because some of the conservatives are also within the UN and other organizations, and they don't speak out loudly enough about U equals U. We need all voices in the same choir coming out strongly on this agenda. We from UNAIDS definitely will be there, and we even were a bit slow at the beginning. Bruce and I have had a number of conversations about this. How do we get the right voices saying it? And that's critical. Not just putting out a public document affirming something. We need public advocacy from the highest levels, across the globe, but all levels, community, political leaders, everybody. Because the win-win-wins and the multiple past that are just so many. When I was talking to Bruce years ago, no, it feels like years ago, I was working in Asia, and it was a no-brainer for us. Sorry, that's an Australian term. There's no logic to not moving on U equals U for so many dynamics. Yet we were talking about how we'd support one of the most respected globally clinicians working on HIV science, who was being attacked by others in Thailand. And Thailand's one of the best example countries of moving innovation constantly. They are constantly improving their response and seeing the success. But that's about the conservatism in the system. So we really need to get those clinicians as a key part of this to empower the community and understand the role of the people living with HIV as part of this change that we all need. So we're very proud to be with PAC and all the other partners in this agenda, but we really need to put this at the forefront. The power at Montreal was great to see the protests, because we can't be quiet about the science. We need to get out there and create the change that's needed for everybody to win. Thanks very much.
Thank you so much, Herman. So important. So I know most of you might have questions, so keep your questions. We're going to go over them in a little bit, but we're going to go to our first panel. I hope our colleagues are online, the virtual panel. The Zoom link, yeah, so we have some of our colleagues who are joining online through Zoom, and they're going to have a panel with them right now, and they'll move to the next panel. But we're going to take some questions during this panel, and hopefully... Hi, Rachel. Yeah, so we have Rachel Bagley from WHO on, and we're also supposed to have someone from from USAID on, and then CDC. How many people are on Zoom? Just confirm. So I think we have, great. Great. So we have all of our colleagues on. So we have Nedzi Gulivica from USAID Mozambique on, and Rachel Bagley from WHO. So basically, this is more about like sharing the science. And I know we've talked about the science and data, but actually, it's one thing to actually implement, talk about the policies, but it's also second thing to actually implement it. And we have no other WHO and USAID, USAID and CDC to talk about how they are using the U equals U message and also the science to implement programs in countries where they work in, and actually how WHO is using the policy and actually advocating for it and telling government to use it as a tool to change their policies. So I'm going to go over to Rachel first. Rachel doesn't need introduction. Rachel is still of my godmother, but Rachel Bagley, I really excited to see you here. Happy for you to join us. Can you tell us about what WHO is doing about the science behind U equals U, and how they're using to implement programs and policies in countries where you advise and work in?
Thank you very much, Michael. Yes, you're one of my real heroes, and thank you, Michael and Bruce, for this campaign and everything you're doing to get these messages out there. WHO has recognised U equals U, although it was before that, since HPTN 052, Mike Cohen's study, which really showed at that stage there was no transmission when people had put on treatment and had were virally suppressed in 2011. And actually WHO responded really quickly at that stage and really released guidelines. At that stage, the world recommended people should start treatment with a CD4 count of 350. And we said then, actually, you should start immediately to prevent the transmission to partners. So, we've been saying it since 2011, and very, very, it took several years for the immediate start on ARVs. When one's looking back, it's a more than 10-year journey, and we continue to state that the science is so clear that if you're on treatment and virally suppressed, there is absolutely no chance you're going to transmit HIV to partners. It's a very, very clear message. We released a statement again to really reiterate that and bring that up to the forefront in 2018. And it's very much part of our testing guidelines in the counselling messages. That one of the things that is really important for healthcare workers to relate it to their clients is that they should get tested not only for their own health benefits, but also to prevent transmission to their partners. So we know there's no question about science. It's really not an issue. What there is a question about is the messaging, and I think this is why it's fantastic the work that Michael you're doing. We've really failed, I think, over the past year to get this message out there, both to communities and both to health workers. So I think it's great, Eamon, that UNA is really on board, because they're such a powerful organisation for advocating messages, and so we'll really continue to bring this to the forefront, because it's still really not widely known. It's extraordinary how many people in communities are not fully aware of this, and make it far too complicated. And we at WHO, our role is to really support healthcare workers to provide better messaging. I think I was in the clinic recently in an unnamed country in Africa, and the nurses were giving really complicated messages about U equals U. The idea that you need to continually have viral loads just to check that you weren't having a fit. I think we don't say use condoms, but they may not work all the time, blah 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 blah. Or we don't say there will be PrEP. There may be, even if you take it well, there may be a chance that you could get HIV. We're so excited about cabotegravir, but that's a very, very powerful HIV prevention option. But being on treatment is the best prevention there is. Of the hierarchy of everything, being on treatment is the most effective way of preventing transmission. And we know that both for public health, effective. It's fantastic to see progress in many countries, particularly in southern and eastern Africa, where they're reaching the 1990s, and you can see the incidence of HIV falling really quite significantly in these countries because of that, people being on treatment. But there are big gaps. I think, again, like what you mentioned, there are many barriers to accessing treatment, accessing cancer, particularly for men. And we know it's because men have need information, and that understanding is not only great for them, but it's going to be great for their lives. They're not going to have to worry about transmission, and for women, they're not going to have to worry about transmission and, of course, transmission barriers. So we really have to do much more to make simple messages and simple, positive messages for healthcare workers, so that they're not making things too complicated for people and not putting too many caveats. So I really applaud you for this work, and your video really inspiring. You've got world voices there in the HIV. We need to get that absolutely out. But I think the real work, this is why fast practices is such an exciting project, is fast practices could really make a difference, not only for community messages, but a really much more concerted effort to engage healthcare workers with a simplified message and really with you.
Thank you so much, Rachel. So important. So Rachel and I, just a little bit history. Rachel and I worked together to sort of work around PrEP implementation in Africa for MSM, and in the last couple of years, and I think the first ever MSM and PrEP meeting happened in the continent, and that's where Rachel came on board and sort of worked with governments and policymakers to develop guidelines for PrEP. And I think it's very similar for what we're trying to do here with you, because your message, like, critically, we want the government not just to adopt the policy, but to co-create guidelines with their communities to how they're going to implement structural issues that affect people getting on treatment, and actually how they're going to promote the message about you equals you. So again, like, I'm really looking forward to working with you on this agenda. Like, really, I think it's really, really important. This is not just, developing guidelines is critical. So also looking forward to WHO having having some guideline or guidance for government to adopt and how to use you equals you message in country. I think WHO is really critical for WHO to do that as well, because right now we don't have that, and I think it's really, really important for government to look forward to WHO creating guidance on how can they use the science that has come out from all of the research, all of the trial we've done around, treatment as prevention, and you equals you, how can they use it to develop programs and policies that their community can get on board with in their countries. I think that's so critical. So again, thank you, Rachel. So excited to see you. Before Rachel goes, anyone have a question for her? She's going to be around, but if you have 1 or 2 questions, 3 you want to ask, or to any of our panelists? Okay. Thank you, Rachel. I know you're going to be on, but I'm just going to move over to one of my other colleagues from USA. Just see her name. We have Nidzi. Nidzi, are you on? Yes. Yes. Nidzi, unfortunately, we don't have your slides showing, but I hope you can talk about the project you wanted to speak about. Or if you can project your slides. Okay, great. Thank you. Thank you for that. Can you tell us about yourself just briefly? Fantastic. We can see the slides.
Okay, sorry, I couldn't talk while I was doing this because I get a bit anxious.
Great.
Can you hear me?
Yes, we can hear you. Go ahead. Thank you.
Okay. the name of the campaign is Social meaning we are human. And this campaign is implemented since July 2020 with the aim of improving men's treatment continuity and adherence by reshaping community and individual perceptions of HIV treatment. I would like to say that in Mozambique, coverage of ART among boys and young men is especially low. And expert data indicates that young men are much more likely to drop out of treatment and to remain out of treatment for longer than 6 months. At the same time, these young men tend to be mostly asymptomatic, less likely to interact with the health system, and are sexually active. So these combined characteristics make young men live with HIV a driving force for the new infection that we have every year. So during our negotiation and inspired by the Men's Part initiative that aims to change the dialogue of HIV to be seen as a chronic and mental disease and not as a death sentence, one of the solutions that we identified to surpass this challenge was to implement a strategic marketing campaign focusing on this population. So prior to the beginning of the campaign, our implementing partner, Int'l, conducted affirmative research seeking to understand the barriers and communication with needs of the target. You can see some of the examples of the messages that they share with the public, but overall, the primary barriers are related to social and are related to stigma. So based on these insights, the first phase of the campaign was designed to address stigma and to normalize the conversation about HIV. And I want to say that at that time, we had very little conversation about HIV in the country. And the second phase that just ended a month ago was more focused on male population, but in both phases of the campaign, the new people's message reinforcement was a strong part. So during the past fiscal year, while this campaign was still running, we implemented the study with a quantitative and a quantitative components. The quantitative components aim to measure the campaign messages, recall, and resonance, as well as the reported impact for ANC behaviors after exposure. I'm going to share some preliminary data that will be mostly focusing on the U+U results. So, almost 2,000 men with HIV participated in the study, and as you can see, this slide measures the proportion of participants that understood the ways of using the HIV transmission network. I want to highlight that overall, only 30% of the participants have understanding of enforcement. So we still have a lot of work to do. And unfortunately, it's hard for us to measure the campaign impact, and prior to this study, we do not have any results. But these results will serve as a starting point for future evaluations. In this slide, I'm showing the same indicator per level of exposure of the participants. And overall, you can see that higher levels of exposure to the campaign are associated with higher levels of knowledge of HIV, of how HIV transmission can be reduced. So with regards to people specifically, you can see that the number goes from 18% among the ones that did not have any type of exposure to 44% among the most exposed to the campaign. Could this be seen as an indication that the campaign somehow contributed to raise the knowledge about U+U? Well, I want to believe that yes, that these SPC intervention and that treatment literacy is still a strong and powerful tool to help improve the program results and the health of the patients overall, of the people overall. Again, this slide is the same indicator, and here I just want to show that knowledge is higher amongst the ART users, particularly with regards to U+U. We can see the difference of 23% of points between the ART users and the non-ART users. So finally, in this graph, in the left side we have male population, and on the right we have female. So our data does not allow us to say that the steady increase in the viral coverage and in the absolute number of patients with deaths was due to the campaign, as we are also implementing several other interventions. However, based on the fact that in this study, 69% of the study participants referred that they exposure to the campaign somehow influenced their decision to start or restart treatment. After further analysis, we may want to consider that there was a campaign contribution to these results. As you can see, viral suppression is stable. We still have 7 to 8% of patients that are not virally suppressed. So we will continue working in these treatment literacy interventions. We are now with 92% of coverage of ART amongst the adult population and 92% amongst the kids. The government and universities we started to implement the testing and treat since 2016. We are now working in several differentiated services delivery models that are more flexible to the patient's needs. So there is a package of information that is being implemented in order to disseminate the importance of U and to actually have more patients achieving the viral suppression target. Thank you.
Thank you so much. That's so important. I think this is part of the data collection that we spoke about earlier on. This sort of data we need to help our government understand how important it is to invest in treatment literacy and invest in U. Do folks have questions for Nitsi? Okay, please, when you use the mic. There's no mic, sorry. You can use this.
She's online. Okay, thank you and good morning, everyone. My name is Mahlodi. I'm from South Africa. My question for both presenters is, the U equals to U. It's equally effective on a stable community where outreach, we can find them. So for Rachel, WHO, are we looking at strategies to look at the highly mobile community, which is undocumented? Because the challenges that we face is you find the highly mobile population presenting themselves as new patients as they move across provinces, across districts. And that is the huge challenge that we're facing, especially at aiming to achieve the U equals to U. And for this is, in their data, did they only focus also on the stable community, or were there pockets of these undocumented foreign nationals? Because that is the challenge that we struggling with in South Africa, that as much as there is universal access to treatment, but they are not stable for you to monitor them and get them to this, because then when you then expect them to come to the next visit, they've moved to another district where they are now being recorded as new clients. Thank you.
Please, yes. Is it Nitsi or Rachel? Rachel, you want to go first?
I'm quite happy to discuss it. This is a really, really critical issue, and looking at data and looking at people. So let's look at the people. So as you said, people are often very mobile, and people come in and out of services, stop and start treatment sometimes. So it's very, what we really have to have is a new thinking about how we support people when we're we've got to really push for undocumented people to receive treatment wherever they are. And I know this often been a real problem for some communities, like sex-trafficked communities who come from neighbouring countries and fear, criminalisation or don't have the papers so they can access healthcare. And that's a major, major barrier to the country's public health. And so we have to make sure, and I'm sure, Amy and Leonard could really agree with this. We've just got to make, from a public health as well as from an individual benefit, people who have these difficulties with mobility and with documentation to be provided with testing and treatment in the same way as for everyone else. And for the data, it's going to be imperfect, but we need to recognise that and really concentrate more on the service for people and look at ways that we can look at the data that makes it more manageable to understand the inconsistencies. But our primary concern is to have services that support anyone, whether they're a new person diagnosed or somebody who knows HIV but hasn't had that that courage to come and start treatment, or it's somebody who's new or got cancer treatment.
Thanks, Rachel. Nidzi, do you want to add to that?
Yes, I want to add and bring the perspective from Mozambique, which is pretty much aligned with what Rachel was saying. First, I want to say that this is why we are investing so much in SPC interventions compared to what we used to do in the past. We realize that without having people understanding why they need to take the treatment and to remain on treatment, we are not going to win this fight. We need to have people motivated and they need to understand. On the other,
I think we lost you, Nidzi. Uh-oh. Now, Nidzi, you become sort of a robot, but like, can you hear us? Can you still hear me? Rachel, can you hear me? Just to make sure that it's not on our fault. Oh, okay, great. So maybe she's in Mozambique, so there's probably she has connection issues. This is when you do hybrid meetings. But Nidzi, we'll come back to you in a bit when you're back on. So just let us know when you're back on, so we can move along. Are there any other questions for this panel before we transition to the next panel? Anyone have questions? Just want to confirm, Asia from CDC, are you on yet? If you're on, can you say hello? Okay, no. All right, so the fun panel. Valeria, and Larkin, and Ineka. You guys can see it? This is exciting. I love this. Social distancing. Still practicing it. Yeah, it's perfect. This is such a power panel, and really excited to be moderating and chatting with you guys. So we're missing Erica Castellano, who is fortunately stuck at the airport, so she was not able to be here, but she sent our love and she sent our note. But I'm actually going to go. I cannot introduce you guys. I feel like you guys are amazing, so it's better you introduce yourselves. So I'm going to go over to you, Valeria, if you want to tell us about yourself, what you do, and then we can move over to Larkin.
Hello everyone, I'm Valeria Archinska. I represent here 100% Life. It's the biggest patients organization all over Ukraine and all across the region. What we're doing, we're making sure that everyone living with HIV has access to medication. We support all the K population group, and we provide care and treatment programs, prevention programs, and also we change in laws and policies.
Hi, everyone. I'm Larkin Callahan, and I want to thank Bruce and Michael and PAC and IAPAC for hosting this session and for asking us to join today. I'm from Gilead Sciences. I lead our global advocacy and community engagement work across our virology portfolio, so HIV, hepatitis, and COVID.
Hi, everybody. And again, I'd like to thank Bruce and Michael and the team for this invitation. I'm Neka Nwokolo, and I'm the head of Global Patient Affairs at Viv Healthcare, and I'm also a practicing HIV physician in London.
Yeah, so this panel is going to be focused on win-win. How do we actually make win-win possible? And how do we change the policies? How do we adapt? How do we bring in new innovations to make U equals U possible and win-win possible for communities and people? And not just numbers, but communities and people. It's really, really important. And Valeria, for your work in Ukraine and around the world, and again, you are hero in who you are and what you've done, and I think you continue to inspire a lot of people in this room, myself as well. So just thank you for what you do and what you represent and who you are. So again, just thank you so much. So for you, what does win-win mean for you, right? Like, what does it really mean, the messaging, and how do we actually implement, win-win strategy and agenda, not just the U equals U message about it, but like the win-win, because I think we focus a lot on the stigma reduction aspect. It's really key and important as well, but how do we get our government to understand that, yes, if you might not care about us, you should, but actually this is not just for you, this is not just for us, it's actually also important for you to invest in this.
Thank you for the great question. And so win-win strategy for me, actually it's U equals U. Why? Because I was diagnosed with HIV 2010, and it was no access to medications. We covered the success, but it's good, but it's not enough. Then it was about self-stigma and self-recognition as a person living with HIV. And this message came, U equals U. And it's really life-changing. When yesterday, you was those infected person that are a threat for everyone, including people you love. You want to have a sex, but you're a threat. And it's very hard to think each time we're having a sex, even with a condom and so on, that it can be a little bit different results out of love and support. And then this message coming, and you can understand, everything is fine, you are fine, you are not a threat, everything is okay. You're just a normal person, like everyone else. This is about changing everything in your life. No stigma, no self-stigma, like a great life. You're just a normal person. You're not HIV-infected person anymore, in this sense. So then it's the next level. When you're a normal person already, this is about recognition of the world, the same message. And this is, for us right now, it's a big fight about changing policies in my country. Because these policies still tell that each my sex is threat for public health. And I should go to jail for 5 years. So maybe I already got 200-year sentence just to be a sexually active person. So according to my government, I'm a criminal. But I'm not. 38 million people across the world, they are not criminals. And actually, I don't like this message because it's a perception of things that we might be criminals. We are people living with HIV. That's not curable yet, but controllable. And we're not a public health threat. And this message, U equals U, life-changing here too. Because what we are doing right in Ukraine, we're trying to put it in law. We still have this a Middle Ages special HIV law, but we're trying to update it and put this a viral suppression achieved and U equals U message inside the law. Because to change law, it's 10 years. It's not just someone's signature that today we want people be accepted by society safe. Tomorrow we don't want. With law, they cannot do this. And what we want to do, we want using this undetectable and equals untransmittable. We want to change the laws in all the countries that still have it. We want to remove travel restrictions. We want to make not just like people living with HIV just accepted by society, like verbally, in some levels, in some circles, but make them really equal to people without HIV. So, and I think this is our win-win strategy. And U equals U, it's like a K message, K point, and our K tool to achieve these targets.
Thank you so much, and couldn't have said it any more better. Larkin, so just from a personal experience, right? Like, I got HIV when I was back in Nigeria as a young kid, and I've been through several iterations of treatments, and there was at some point I wasn't on treatment, and but I was on treatment, and different colors. My friends, have called me, you have like 15 medications you're taking. Like, I've tried to hide the pill bottle because it was red, it was blue, and people have the color in their mind. And the role that, listening to community and being innovative in how you develop new therapeutic it played a key role in my staying on treatment back in Nigeria, because I was able to tell my doctor, maybe you should change the color, because everyone knows that the blue pill is associated with being HIV positive. Maybe you should change the way you give us pill. Should it be 2? Should it be 1? Should it be 3? I can't take it every day. I want to take it once a day. I want to take it twice a day. Listening to community is so key. So from Gilead's perspective, how is it important, your innovations in therapeutic new innovations for HIV medication and treatment, how does it link to the win-win strategy and the win-win agenda?
So I think at the core of all of Gilead's work, especially when we think about new drug development, is the idea of options and choice, right? And so it's really important, we know, for people to have sort of a plethora of options. And we know that when people are able to select in partnership with their healthcare provider the option that works best for them, they're more likely to be able to be adherent, which can ultimately lead to U equals U and win-win. I also want to add that community and advocacy really drives the development of everything at Gilead. And so you gave a great example, from before we have a first patient, first visit in a trial, we communicate with advocacy groups and we say, what is most important to you? What is most impactful for you? What will help you achieve a healthy lifestyle? What will help you get to the endpoint that you want to get to? And I think from the perspective of long-acting injectables, which we have a great pathway for now, we've modified a lot of our work based on the feedback we've gotten from community and from advocacy. So it's really, truly key. The pill size example that you give is great. We have some fantastic long-actings on the market now. We also know that different dosing options, different dosing intervals, different routes of administration are really important for individuals. And so for us, what drives all of our work is really the options. And it's really hugely important that we get that insight from community advocacy as we're developing our new therapeutics to make sure that they're successful. I would also add that, aside from drug development, Gilead does a lot of work championing U equals U with governments as well as with community organizations. And so something that we're able to do is amplify using our platform and our visibility. Gilead has a seat at a lot of tables, and we do see it as our responsibility to amplify the message of U equals U and win-win and how important it is. And we're very able and happy and excited to do that. And that matters for whether or not we're communicating the innovation of our drug to a payer, to a government, or whether we're communicating the importance of our partnerships with other community organizations, other industry leaders. And it's just it's a really easy agenda to adopt, right? It's a win-win-win-win-win, as everyone has been saying. And so for us to be able to amplify that is really key, and we owe it to community and advocacy to do that, and we're grateful for the opportunity to do so.
And I'm going to go to my sister from another mother from Nigeria. My Igbo sister, Neka. Back to the similar question to you. Why is it important, for pharma companies to listen to community and to be innovative in the way you develop new drugs for HIV treatment?
Thank you very much. And I echo very much of what Larkin has just said. I mean, ViiV Healthcare is absolutely committed to win-win and to the U equals U, or to the win-win agenda and to U equals U. And as Larkin talked about choice, and this is really important. And actually choice is important not just in HIV. We see really great examples of how important choice is with regard to women's access to contraception. You know, the wide range of contraceptives that are now available to women have had a significant impact on unintended pregnancies, and it's also the case, should be definitely the case for people living with HIV or for people who want to prevent themselves from acquiring HIV. We know that if a method of contraception is not acceptable, it will not be used at all, or it won't be used properly. And we see people, you know, I'm a clinician, so I see people struggling with antiretroviral therapy. And the fact that now increasingly, you know, the majority of HIV pharma companies now are widening sort of expanding the choice of types of antiretroviral therapy is really in recognition of the fact that people's needs change over time. And a person who actually is doing okay with a particular modality of treatment at one point in their life may have their circumstances change, and actually that treatment modality might not be okay when they change their circumstances. And acknowledgement of that really drives the sort of movement towards widening the range of antiretrovirals and preventive options that are available. But the other thing that's important, and that VIV is very much involved in, is issues related to access to care. Because it's important to have options with regard to treatment, but actually if you can't go to the clinic to get those treatments, or if you live in somewhere that is so remote that you really struggle to get treatment, then what is the point of having really good treatments? And one of the things that we've been involved in is various innovations to help people to be able to get to clinic, or to help in a sense, clinic come to people. So we're doing implementation science studies using ride-sharing platforms to help people go to their clinics where they live in rural areas. We support studies that allow or that help nurses to go to people's homes to provide treatment for them. And it really is about speaking to communities. And a lot of the talk that we've heard today has been about engagement of communities. And these are things that we cannot do ourselves. We have to understand what communities want and then adapt what we do to communities to enable them to access the care and the treatment that they need.
So basically, I wanted to ask this. I think, you know, we all know one of the issues and one of the things we keep seeing in our communities on the ground is, like, you know, treatment stock out, you know, access issues, and government not able to have enough treatment in place to make sure community have access to it, right? Can you, from your perspective, share with us, like, what are some of the recommendations, again, from, I know, you know, you guys work with big government and all of this stuff, but I think it's important for community to understand, like, what can we be doing better to make sure we avoid stock out? Because again, to achieve that first people have to have access first. And the treatment has to be, you know, get in the hands of people. And so what is pharma companies doing to make sure we avoid stock out? Or maybe you can't necessarily solve the issues, but, like, what are the things you can share with us that it's important? Again, also it goes up to the question about pricing for the drugs, right? Like, can all country access the most innovative medication for treatment? And can we make sure we are pricing enough for countries who might not be as rich as the US or in Europe can access the best innovative treatment so that people can achieve U equals U? Want to start?
Yeah. So I think, you know, as I mentioned, you know, we have very robust government affairs and policy teams who work very closely with payers and governments, both on a national level as well as on a regional level. And so whether it's with a specific country governing body or a more regional one, their role is to communicate how an innovative therapeutic helps people achieve viral suppression, right? And so in communicating that, helping governments understand the importance and the innovation of a specific therapeutic, whether it's Gilead's or another's, to help people achieve viral suppression, and how that benefits more broadly broadly their community and their country. So it's not just, as you mentioned, the individual, this is how ensuring someone is able to stay on treatment improves the overall health status of the broader community, right? And so that is something that we're very actively engaged in, again, both on a national level as well as a regional level. In terms of the pricing and access question, Gilead has been a part of MPP since 2011, and we are committed to that. We also know that's not the only way for people to access treatments, and so we are actively in conversation with advocacy and community groups around the best pricing structure, access structure for a specific therapeutic and a specific region, and it might not be MPP. We have a number of access programs, we have medication donation programs as well, but again, that we're open to a variety of options, and we do rely on that communication with our communities and our advocates to sort of help guide that sort of conversation. We also welcome them into the conversation with governments and payers, right? So it's important that we show Gilead is doing this in partnership with advocates, and so when we go to the table and we speak to a payer or government, it's not just Gilead as a drug company, it's here's Gilead along with all of our partners, our community partners, our advocacy partners. This is why this is really important. And so expanding the seats at that table is really key for us so that they can hear the voices of those most impacted.
Thank you very much. How do I better that? No, and I think I can just echo again a lot of what Larkin has said. With regard to stockouts, I think it is really important to have good relationships with the relevant people kind of in the countries where medicines are being provided. And we have, we have people within the company in government affairs and market access and so on, who have those good relationships with people in the company, with organizations that are involved in the production, in the supply chain of medicines in order to try to ensure as much as possible that stockouts don't happen. But unfortunately, sometimes things happen that are beyond many people's control. But I think it's also really important to recognize that and to try as much as possible to mitigate against those sorts of potential problems. With regard to price, again, ViiV has a really good relationship with the MPP, the Medicines Patent Pool, and is in ongoing conversations all the time about issues relating to pricing. But also, it's not just about the MPP. There are other bodies who have an influence on pricing. And it's really important to always be in communication with those people and to kind of widen as much as possible the numbers of people who we speak to in order to make sure that people have access, that as many people as possible have access to good treatments as is possible.
And I would just, you remind me, I would just add, in terms of stockouts, we had a great example when the war in Ukraine started. We had immediate communication from our partners on the ground in Ukraine and in surrounding countries saying, here's the issue. We were able to respond because we have such strong embedded community advocacy teams. We were able to respond within 10 hours and say, here's what we can do to try to help aid that. And so, again, it's those tight relationships, those immediate relationships, the consistency of those relationships so that community can trust us. They know that they can come to us when they are faced with those issues is also really important for Gilead.
As for communities, for us, it's firstly access to innovations. Because right now we have this amazing injectables, long-acting, but we do not have access to it because of price. And actually it could be a good solution for migrants communities, for countries who's have emergency situations, because just one injection, months or 2 months, and this could be a PrEP, and this is a treatment, and this is actually could be good response on this, a win-win strategy, U equals U, because it's a full control of your health, and it's you should have this choice. So this is one thing, and another one, it's about removal legal and structural barriers on the way to treatment. Because okay, we can have a meds, but if you're afraid to go to the clinic because you are criminal in your country, if you cannot get a PrEP because you can be beaten by stones to the death because you are a gay man in some countries, so even with all the medications you have in your country, we will not gonna get a win. So, right laws, right policies, and access to innovations, and we can do it.
Thank you so much. And I'm going to open it up for folks who have questions or comments for our amazing panel.
No, thank you very much, and thank you for sharing. My question is for the pharmaceutical. The core business of pharmaceuticals to produce efficient, cost-effective medicine. But what I need to understand is, working with governments, is there a specific standing budget that address community involvement? Because sometimes you find that the budget is ring-fenced into the production and accessible medicine. But do we have money from the pharmaceutical point of view that is addressing community needs, that is not inclusive in the production and whatever access of medicine? Thank you.
Before you answer that, anybody has more questions, you can just take 2 at the same time, or 3 questions. Don't be shy. Okay.
So the quick answer is yes, we do. We have significant resources and budgets specifically dedicated to communities, both their own activities as well as those that are being co-created by us, and it's fairly robust. So Gilead has a grants program. Gilead, which is we're actually the #1 funder of HIV/AIDS programs in the world, and so we're very dedicated to that. We also have a number of programs where we co-create initiatives across our medical affairs teams, our clinical teams, our public affairs teams that may not have anything to do with the development of a specific treatment or therapeutic, but do inform the work that we do, and ultimately with the end goal of benefiting those in the HIV community.
Yes, and that's a great question. And so ViiV does exactly what Larkin was saying, but also with regard to medicines. I mean, one of the most important things I think that needs to happen as a medicine is being developed is to understand the unmet need for that medicine. So that when a medicine is developed, actually it's developed to identify a need. And the only way that you can identify such a need is from communities. And so speaking to communities to understand what the needs are then hopefully then leads on to the development of medicines. But at every stage of the development of a medicine, there is, and not as much as there should be, but increasingly there should be scope to have community engagement to make sure that what we're doing is the right thing. And there are budgets for such a thing. They're not necessarily woven into the medicine development budgets, but as Larkin says, we have budgets for community engagement, and that's what they're used for.
Hello, I'm actually referring back to Eamon's comment about Ben Collins. I'm based in London. I'm with Reshape and EATG. I'm referring back to Eamon's comment about making sure we get the right voices talking about U=U. And this is kind of a question and a comment. I think pharmaceutical companies have done a great job about increasing community involvement, and I appreciate that. I think what's happening here is, I know that there's U=U, and promoting of U=U, and there's also another narrative which is around PrEP. And I think that it's very hard to respond from a pharmaceutical company when you have differences in the community. So I think this is a community responsibility, but I think we need the support and encouragement for cooperation. My response about U=U and PrEP is we want both. And we want more prevention thinking, and we want linkage between treatment and prevention as it's naturally expressed in U=U. So I guess it's, how do we, as the community, ensure that our community leaders are actually looking for the best for all of us rather than promoting one thing or another?
You want to just take that, and I can come over to you guys?
Thank you, Ben, and that's a great question. And I think, it isn't about one modality. It's, what will end the HIV pandemic is combination prevention. And that includes all the modalities of prevention that exist, including treatment as prevention, biomedical technologies, behavioral technologies, although we know that those are challenging. And, and we shouldn't dismiss condoms. Condoms work for some people. And I think often what the narrative in communities sometimes is that it's about one thing. And it seems to be mainly about PrEP. And that's not a bad thing, because PrEP is highly effective. But as is the case with treatment, with regard to what we were saying before, it's about choice. And it's also about the fact that people's choices change depending on their circumstances. And so I think, I think the tendency, is for human beings to kind of sit in silos and only talk to people who talk the way that they do. And so I think it's really important that communities come together, even if they disagree, to hear what other people are saying, so that they can understand that there are other points of view, and that the only way that we can move on and end the HIV pandemic by 2030 is by all of us coming together.
Yeah, I mean, I would just, in complete agreement, and I would just, not much to add to that, except that I know internally at Gilead, historically, we probably had too much of a siloed work stream on the treatment side and the prevention side. We're working very hard across a number of functions to merge those and say, if we're looking at a screening and linkage to care model, it's screening and linkage to either treatment or PrEP, right? So it's not just like, oh, you tested negative, send you on your way. It's how can we help link you to PrEP or treatment? So I think we are working to strengthen that internally. Of course, we can always do better, but I think we are committed to that internally, and we, again, look to our community leaders to help guide us on that as much as possible.
Yeah, just wanted to add to that, the partners we have on the win-win agenda, these are organizations and partners who actually work on both sides, right? They work on PrEP implementation, they also work on treatment access issues. So I think that's what makes win-win so unique in its way we're framing it, that these are advocates who believe in the science, who follow the science, regardless of which side you're on. It's like the science has shown us that this works, this is effective, and when you get on treatment, you can achieve viral suppression, and then you can not be able to transmit HIV. And then gives you choice. And if you're HIV negative, you want to make a decision on your own, you can get on PrEP. So gives people the messaging and give them science and just let them follow the science. I think that's what makes our campaign, not the campaign, but the strategy really unique in the sense that we are bringing activists and communities across the world, across the board, who work on both issues to come together and design an agenda to get people on treatment, to achieve viral suppression, but also to give people choice. And they can choose whatever works for them, based on where they are. It's really, really critical. Question? Yes, sorry.
Hi, my name is Stephen O'Hare, and I'm the director of HIV Ireland. Just want to come back on the budgets question, because I think this is really good. So we're a net beneficiary of programs that you just spoke about budgeted community initiatives. We've benefited from the Gilead Zeroing In project, for example. So we are putting a mobile testing unit on the road, and that mobile testing unit is going to be going into community spaces to work with GBMSM and also with Black and minority ethnic communities in Dublin. And the idea is that we increase people's access to testing. That's particularly important coming out of COVID, where people have stopped coming to clinics and the clinic services were pulled back a little bit. We've also benefited from ViiV, from GSK as well, in terms of a lot of the programs that we run. We go and we seek funding and we get funding. When I went to the state, and we do get a lot of statutory funding, we get a lot of funding from government, about 70 to 80% of our funding comes in that direction. When I went to the state and said, look, we're putting this mobile testing unit on the road, it's got a time-limited project timeline, we want to extend the life of this, how can we do it? Can you help us buy this van, or can you help us invest further into this van? And they said no, because it was funded by a drug company, by pharmaceutical. And I thought, here's a disconnect. There's still a disconnect between the money that we can bring in, the budgets that we can bring in to actually provide services on the ground as a charity, as an NGO, and what the state will support us to do because of the perception or the optics of working directly with drug companies. So there does have to be more, or there probably has to be more work to do to bridge that gap between working in a co-funding or a co-initiative manner. So my question to you is, what more can be done in that direction?
Great, rapid answer.
Thank you very much, and it's a great question. I mean, I think that very quickly, the answer is to help people to see that the benefit, to see what the benefit is. That it doesn't matter who's doing it. This is what we're trying to achieve, and any way that we can achieve what we need to achieve is worth partnerships, even with partners that you might not necessarily naturally align with. We're all trying to achieve the same thing.
Yeah, I would agree, and just thank you for that comment. That's very helpful information for me to take back to our government affairs colleagues as well, and to inform further conversations with governments, as well as our grants team, to make sure that they're aware of that. So thank you.
Thank you, guys. Amazing. Thank you, our panelists. And thank you, Valeria. Just so before we wrap up, I just want to say, before I give it to Bruce to wrap us off, just want to say this has been such an important conversation, and the reason why we did this and why we're doing this, and sort of the reason why we believe so much in the win-win agenda, it's like we want to make sure these are community voices, and community strategies. And I think most times we design projects from a top down, but I think this time we're doing it from bottom up, and we're really focusing the community on the ground to let us know what are the issues that are important to them that they want to make sure we address collectively together, and co-create work plans and co-create agendas together with PLHIV networks on the ground, groups on the ground, to make sure they can understand what the data says in their country, and so we can support them. And partners who are part of our agenda, they are, PLHIV networks, sex worker networks, and injected drug users networks, and young people networks who are part of the agenda in different countries. And I think the most important thing we are taking away is that they are part and parcel of the agenda, and it's so important that we focus on them and their needs, regardless of the countries. You might see people living in the UK, there are issues in the UK too, in France, in Germany, in Brazil, in Colombia. There are issues that are unique, that might not be the same, but like there are issues still that makes people not access treatment or not understand the treatment that they are on. And those things are really critical for us. So, Bruce, wrap us up.
All right, great. Okay, so just really quickly, I just want to give some examples of how we're going to use the win-win agenda to increase access and reduce barriers to care for people with HIV. Very, very specifically. In Japan, right now, and I saw this myself just before the pandemic, people with HIV whose CD4 counts are above 500 will not get treatment from the governments. So we were at a forum. A man with HIV stood up and cried and said that my CD4 count is not low enough to get to U equals U. So what we're doing, and we will do this year, we will get this done, is we're going to the Japanese government with the Japanese HIV research societies, and Michael said, communities, and we're saying to the government, this win-win approach, we're saying, not only is it the right thing to get people with HIV, everyone treatment, because of the positive health outcomes, it's also the way to end the epidemic in Japan, because those folks who are above 500, not only is their health declining, because in the reality, the government may not care about health and access and rights, but they are also infectious. And those folks who are not getting treatment are also passing on HIV. We'll use that ugly word because we want the Japanese government to understand there's a safety issue. You need to allocate your funds to those folks, and you need to change your guidelines to allow access to everyone. So these are things, the same thing with viral load testing access in places where there's limited viral load testing access. People with HIV are not going to stay on treatment if they don't know that they're healthy and they can't pass on HIV. We need to understand viral load testing. We need access to testing. Why? Because that will keep people with HIV healthy and will tell governments, many oppressive regimes who don't care about people with HIV, and that's the way to end the epidemic, save healthcare costs. So this is how we are going to change the advocacy narrative globally for everything that keeps people with HIV healthy, keeps everyone healthy. That's a win-win. Thank you all for being a part of this movement, sharing that message. We're going to make a lot of change together on policies around access for everyone. So thank you.
Thank you, Nidzi. Thank you, Rachel. Thank you for joining us. Thanks, everyone.
Check. 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 Mejor. Mejor. Oh, perfecto.
Can you hear me?
That if, because of the signage outside, there's leveraging a cohort of champions. If you're in the wrong room, it's next door, but if you're here, we're happy to have you here. Is there a way that I could actually see, señor, disculpe, ¿es posible de ver las diapositivas arriba? Gracias. Anyway, it's really a pleasure to be here, and I want to thank the organizers for inviting me to the conference. And what I'm hoping to do is to sort of walk through some of the things that we think about from an implementation science lens as we're sort of trying to roll out or scale up evidence-based interventions. I want to acknowledge a host of people who've contributed to this presentation from Yale, from our work in Kyrgyzstan, which I'm going to present a little on, Ukraine, and our funders, including the IAPAC Fast Track Cities Implementation Science Fund and the National Institutes of Health. What I hope to cover during this is what is and why use implementation science to guide your work in the field. I'm not going to dig too far into the weeds to go into all of the implementation science elements of that, but I will provide some resources for that. Talk a little bit about the importance of stakeholder engagement when sort of aligning the implementers in the field and those people who are guiding the research elements of that. To really identify why it's important to target implementation gaps. There's a ton of evidence-based interventions out there, but sort of identifying the context, what is the right intervention that is really dealing with the biggest elements of the implementation gap is an important part of that, and I'll give some examples. And I was going to try to get to some of the work in Peru, but I won't be able to do that just given the time frame at this point. So here's a way that I like to start thinking about implementation science. These are a ton of the words that are presented in a word cloud that we often think about. You see intervention as one of the biggest ones, evidence-based, of course, dissemination, knowledge, et cetera, that we sort of use, and a ton of other words. And you'll see that throughout the sort of the evolving field. I've been in the implementation field for about 20 years, and that's relatively early on in terms of the implementation science range, but the terminology has changed dramatically. There's been a lot of mixing of terms, And I won't be able to completely disentangle all of that. That's usually part of the course that I teach for the public health students, and that is over the course of a semester. But I'll try to get into a little bit of what's there. And the reason why we think about implementation science is this sort of 17-year odyssey to get from the sort of the original synthesis of evidence to getting it sort of scaled up and sort of fully introduced into practice. And this really only occurs for about 1 out of 6 evidence-based interventions for which there's demonstrated efficacy. And so how do we sort of accelerate that process along that 17-year odyssey? And so what ends up happening without sort of effective implementation is that you just let it happen or maybe help it happen. But whenever you are using sort of an effective facilitation strategy, and that really accounts for about 85% of the implementation. It doesn't account for all of it, but the largest part, that will actually sort of accelerate the process to really about 80% of interventions over a much shorter time period. And it's really important to recognize that even though you may get funded for a 1-year project to do implementation science, it oftentimes takes a lot more time than that to sort of really understand, to explore, and to prepare the setting for your work, and to then be able to then fully implement. And then, of course, you've got a real sustainment plan. By the way, if anybody wants my slides, I'll be happy to make them available, so everything's open access with me. So the definition of implementation science, for those of you who are not sort of spending a lot of time in the field, it's the scientific study of the methods. So it's not just an intervention, but of the methods to promote the systematic uptake of research findings, that is the evidence basis, into real-world settings to really have some element of effectiveness. And it's part of this sort of language of the diffusion, dissemination, and implementation continuum. And diffusion is really the passive, just untargeted, letting it happen, if you will. Dissemination is more of an active spread of these new target practices to a specific audience. And then implementation is really the process. It's those processes, changing the processes along the way. For instance, if you have an algorithm to initiate antiretroviral therapy and you have all of these sort of steps where we went from probably a several-month time period to get people initiated into antiretroviral therapy to fast-track starts, test and treat, moving that to nearly same-day treatment. It's really sort of changing those processes, putting in sort of effective checklists and being able to move through that quickly that allows you to scale up. So it's removing a lot of that redundancy. And then as part of implementation science, there's a lot of theories, models, and frameworks, and those will be bandied around in almost every conversation that you have. And just to sort of give you sort of a taste for that, there's over now 100 theoretical frameworks to guide the science of implementation. We're not going to go over any of them specifically, but I'll give you at least a heuristic. And then there's an online toolkit where you can put inputs into that and maybe decide what is the right framework that you might want to use. Jeff Curran really sort of outlined this a little bit because it can sound very complex if it's not something that you spend a lot of time doing. So the evidence-based intervention, for example, ART or PrEP, is the thing that you do. The implementation strategies are the stuff that we do. For instance, if we want to have HIV testing to sort of highly stigmatized populations, do we move it from the online to offline? That is a strategy, the stuff that we do in order to really help the people, places do the thing that we want them to do. And then the main implementation outcomes are how well they do the thing. And there are outcomes that are both at the patient level but also in the process level. In other words, the process might be the time to initiation, and you might go from 3 months to 3 days or something like that. And so that is the thing that you're trying to do, is to do it as well. If you're trying to make sense of all of these implementation theories, models, and frameworks, this is a really nice sort of paper. It's a little bit old, but it's relatively well done. There's a few more models that have been added to this by Per Nilsson. And it really looks at essentially 3 different elements and 5 different types of frameworks. There's process models that tell you the processes. They're oftentimes the Gantt charts that you sort of set up. There's the determinant frameworks, which are the ones that tell you the things that are likely to actually influence the outcome. There's classical theories like diffusion of innovation, Rogers' diffusion of innovation, which would sort of explain it, but it doesn't actually give you a sort of a framework to evaluate it. There's those that are implementation theories that have sort of come up on their own. And then there's evaluation frameworks. Do you have something that you can set forward and you can put certain metrics to it? And here's some examples of some of the ones that are probably the largest ones, or the most commonly ones used in the field. Among the determinant frameworks, which is very common, the CFIR and the IPARIS frameworks are two of the most common. And among the evaluation frameworks, REAIM and EPIS are two of the more common ones, and then a number of others in those areas. For those of you who are just getting started or working with a team of people and want to get more information, this website, the Dissemination Organization website, actually has a way to go in and put in things like how do you plan for it, how do you select the implementation framework. There are situations where some of the implementation frameworks don't really contain all of the elements that you might need. In other words, it might be bereft of things like exploration and preparation. So you might have a reason to combine that, and this gives you some insight into when you want to do that. Sometimes you have to adapt what you're doing in terms of your implementation, and it gives you some different elements of that to use as well, what to use. And then many of these frameworks have their own independent websites, but this framework brings them all together. It gives you some of the measures that you might want to use. Like, what is the organizational climate? If you think that the organizational climate is one of the major things that might get in the way from your exploration of what's going on, you might want to use those kinds of measures to sort of see what can you change. And if it's the organizational climate, it's oftentimes people at the leadership position who have a major role in sort of making the change. And so you can measure that over time to see whether what you're doing, whether it's an intervention sort of reducing stigma, for example, around certain things, does that actually change the organizational climate? Is the organizational climate so siloed that everybody operates from the higher level? Then you actually will focus on the change leaders or the leadership scale or the types of things that you'll use. So it's really about picking the right measures. When you get to some of these interventions, people sort of will go through here, and for instance, the CFIR, the Consolidated Framework for Implementation Research, has got 39 different domains, and you certainly don't need all of them, but you can go through them and pick the ones that might be useful. And then one of the things that we're really trying to do in implementation science is many of these scales that are standardized and they're really quite effective, they're long. And so how do you actually make it so that there's not a huge research burden on that? So these scales are constantly evolving as you move forward. The way that I like to talk about implementation science is to really think about whatever it is that you want to do, you want to be able to do it faster, cheaper, and better. And that is my sort of ongoing mantra. This is from the systems management folks from over a couple of decades ago. These are the folks that got me interested. These are engineers, by the way. And this is for thinking about how you sort of engineer the processes for actually putting people on the moon. And that's where a lot of this sort of derived from, that it moved into organizational behavior and then has now made it into health services. So there's, I think oftentimes for those of you who are in the field, either as the implementer, the evaluator, or the person who's guiding the research, there's oftentimes a tension between those who are doing the real-world implementation, that is the implementers, the people who are on the ground, who are doing what it is that they're supposed to be doing, and then those who are studying it or facilitating it. And those tensions are really sort of things that you should be expecting as you go forward, and there are ways to mitigate some of those tensions. Those tensions can happen, in multiple different domains along the socio-ecological framework. For instance, your funders, let's say it's the Global Fund, is saying we want X, Y, and Z done, but the people on the field don't really see that as a high priority. We can sort of think about the focus on key populations in certain areas that maybe the Global Fund wants to reduce that gap. But the people on the field are really very excited about doing what they've been doing. They've already done something well, but sort of moving that and shifting it to sort of a new focus area can create a conflict, because sometimes the people don't know what to do as they're beginning to sort of think about this sort of re-implementation, if you will. There's also can be some tensions between the implementers themselves and the actual targets, and so a disconnect between the people who are actually providing the services or guiding the services and the actual targets. Sometimes it's the clinicians who don't want to do things the way that you want. I can certainly say that in many areas where I've been working on facilitating, sort of faster PrEP delivery or faster opioid agonist therapies, there's a set of processes, a set of guidelines where people like to go through that. And then the minute you begin to change that, that seems very fearful or concerning. And it's because what ends up happening is that you are really going to get the outcome that your system is designed to do. And the more sorts of steps along the way that you have, those are the types of things that are likely to get in the way of being able to do it. And so it's really about sort of encouraging people to do things differently. And there's a real tension around that. And I know that I'm also a clinician in addition to being a researcher. And when people tell me that maybe I should be doing things a little bit differently, I sort of, wince a little bit, and it takes me a few seconds to sort of step back and really rethink, well, maybe all of those things that I really thought I needed were important, but they're not, or maybe they're not important right up front. In other words, I might need to know that a person, doesn't have HIV before I start PrEP, or I might be able to sort of get that information to them in a day or so and be able to sort of start the initiation. One of the things that's been a driver, at least around medications, is that when patients come in, they really want to walk away with something. They don't want to walk away with a blood test and say, come back. You know that from the oncology literature, you know that from the HIV literature, you know that from all literature, and that's not the way that our systems have developed. And so it's really about flowcharting. What does it look like for the clinician? What does it look like for the patient? And are there things that can actually be rearranged? We oftentimes like everything all sort of checked and done in advance, but maybe perhaps getting them in, getting them started and excited to do something, and then bringing them back and then asking all of those other questions. One of the things that's been a really important element of stigma reduction strategies is to really not go into the sort of the key population issue so that people don't sort of bring in their own internal biases and prejudices. And so it's really the patient, you treat them. And then if you want to take a real detailed sexual history or any of those other sorts of things, or drug use history or something like that, you can sort of change the way that you do that, unless it's going to majorly impact the clinical care that you're giving. Now, these outcomes, in terms of implementation, are likely to be optimized whenever you can create synergies, that is, sort of common goals to do that work. And I'll talk a little bit about really having the community informed and involved in the process where you align the benefits and the goals. And some of the work, for example, that we've done is trying to do evidence-based practices like PrEP or opioid agonist therapies or even antiretroviral therapy in criminal justice settings. And you can imagine that there's a tension between what I call the public safety, that is, we want to keep our correctional system safe, or we want to keep our public safe, let's say on probation or parole, and then we have our public health goals, which is to get people tested and treated. And even though there's common goals, there's ways to find overlap and alignment. And I'll give you an example. One of the ways of doing some work in prisons was that if we could actually get more people on opioid agonist therapies, you'd have less people injecting and less correctional officers, if you will, who might get stuck by a needle. So finding those common areas. And that oftentimes requires a process that takes time. So the 4 ingredients that I think of when I'm doing implementation research is really making sure that I get the implementation question right. In other words, am I targeting the right step and introducing the right intervention into the right setting? Some interventions don't fit well in other settings, maybe by virtue of the way that the healthcare system is organized. So something that may work in North America may not work in developing economies. And so you might think of that. Some of the things that work really, really well in sort of emerging economies, such as task shifting. The high-income settings are really, they've been quite slow around sort of modifying and adapting to that. So I would even say that the lessons move in both directions. Really having an implementation team that is often multidisciplinary. I have engineers on my team, I have sociologists, I have medical anthropologists, I have mathematical modelers, and so really bringing together a group of people who are multidimensional and sort of thinking more holistically about this. I know that in academia, the idea of team science is not fully endorsed at most institutions. Each investigator is intended to be an island in themselves, but I don't think that that's the current environment. And it certainly is not a successful pathway in implementation research. And then I think it's important to make sure that you really identify who are those stakeholders in the community. And the stakeholders in the community are going to be really important, and there needs to be some information sharing and some guidance that happens between that. So when the researchers have this sort of this ivory tower sort of strategy that they want to put in place, and the community says that's just not realistic, it's not going to work. And then, of course, there's oftentimes sort of some misperceptions or some learned perceptions that can happen through what I call collaborative learning, where each stakeholder really teaches the other people along the way. It improves the quality of the research, and it ultimately will improve the quality of the outcomes. And I'm going to be presenting some of these things in real-world settings through a case example by our fast-track cities work in Bishkek. And then, of course, making sure that you are really utilizing the right models, theories, and framework. And that sort of website that I mentioned before is a really nice place to start. So just sort of unpacking this area around the community partners and their involvement. What happens when you do this? It certainly, by involving the community and the multiple stakeholders, it improves trust. It's likely to have a greater impact. You're likely to get more out of your implementation than you would otherwise. And it also improves the communication flow. And you can imagine that if you're doing something and let's say you hit a wall, that the implementation is struggling, and it may be that there's a structural issue that's getting in the way, a law, an ordinance or a policy around the way, or treatment guidelines, for example, that are getting in the way of one of the processes that you've identified. Oftentimes that feedback back to the community recognizes that maybe this is really not what needs to happen, and it will result in some policy changes or some guidelines. And so in some of the frameworks, those are called bridging factors, and it's the bridging factors between what I call the outer context and the inner context. The inner context oftentimes being what's happening between the patients and the providers at the clinic level for many of these health-based interventions, and then those that are outside of it, such as the organization of the healthcare system, the funders, and other sorts of things. And I'll show you an example in one of the frameworks that we're using in Bishkek. And then what ends up happening is oftentimes there's shared leadership. One of the things that we've recognized is that there are people in the community who sort of really emerge as leaders in this field. And they're the ones who are going to be really key stakeholders in the sustainment or the maintenance of whatever it is that you're doing. So if you're able to tackle many of the processes and make them more efficient and improve the outcomes in terms of what it is that you're trying to show, these are the people who are going to keep what I call drift back to where that's happening. Because when the research is done, oftentimes many of the researchers they're parachuters. They drop in and they drop out. And so there really has to be a legacy of what's going to be sustained long-term, and a group of committed partners who do that. One of the things that was earlier on in terms of the 4 key elements is sort of making sure that you've got the right sort of research questions. And oftentimes as an implementation researcher, I will be asked to sort of provide some feedback in terms of what people are doing. And let's say, for instance, if they're looking to introduce an evidence-based adherence intervention, for example, and you look at the sort of the cascade of care, and you have the proportion of people who are on antiretroviral therapy and the adherence rate is equaling that, that would be, there's not really much of an implementation gap, but it's where you see the largest gaps in what your needs are is where you should probably start first, because you're likely to have the most impact. There was some really elegant modeling that was done by Skarbinski in the US, who actually looked at it a slightly different way. And that is, if you look at the HIV treatment cascade, which is the right side of this graph, he actually attributed, or his team attributed, the proportion of new infections that were attributed to sort of gaps in each of those. And so that would be another way of thinking along the HIV treatment cascade. But also, I will say that there's a prevention cascade that's really important in identifying the right interventions. The way that you deliver them in key populations is important. I've gone into some places where They're really trying to get PrEP going, and they're trying to do it in the MSM or the trans women communities. And they are trying to apply the same metrics and the same elements by having people go to, let's say, the AIDS centers, which is not exactly where they want to be going for doing this. And so changing the way that you deliver it, moving like the Chelsea Clinic in London to a kiosk-based program, having multiple touch points. So that was done in the EPIC New South Wales study for PrEP implementation. These are the types of things that you have to think about. So these delivery strategies are often changed in some ways, either by truncating them, modifying them, or putting them in places where they might not otherwise be done before. But really identifying the right place or where the greatest need is the intervention that you're selecting for that one that is likely to have a lot of traction. And that's part of going to be some of your exploration sort of work that gets done in sort of preparing before implementation. And then is that intervention likely to be acceptable to the community that you're sort of reaching? Of course, you've got a couple of goals for those individuals who are at risk for HIV, and that is to keep them from getting infected. But if they do get infected, then to really make sure that they are diagnosed and adequately in treatment. And then for the treatment cascade, your ultimate goal is viral suppression, but there's multiple steps that may get in the way, and those drops are really going to be important for deciding. I'm going to demonstrate some of these things in the project that was funded by the Fast Track Cities. I think it's really important to sort of recognize the work that IAPAC is doing, but I'm going to then bring it back to a sort of a larger non-urban area. Bishkek is the largest city in Kyrgyzstan. When I'm often talking about this, they say Gesundheit, where is that? But we've been working in Central Asia for quite some time. It's that area of red over there. This is an area that, in general, is one of the only regions, aside from the Nima region, that has really got an increase in new cases, and mortality is present. The prevention is too low. The treatment as prevention is too low. The treatment coverage remains too low, and therefore it's leading to excessive mortality. And in Kyrgyzstan, you can see that it is emblematic of this region. And what's really interesting about this region, relative to other regions around the world, is this is an area where the epidemic is primarily driven by people who inject drugs, which is mostly opioids. And so the strategy that you might put in place may look a little bit different than it would be in other places. Here's the cascade of care for at least two overlapping syndemic conditions. The HIV cascade, where you've got a low diagnosis rate, even a fairly reasonable gap in being on antiretroviral therapy, and the viral suppression levels are about 33%. Then if you look at the opioid treatment cascade, there's only 5.8% of the people are getting adequate coverage, and WHO recommends targets of 20% in order to sort of slow down the epidemic and to reverse it. You would need about 40%. One of the key things about this is mathematical modeling studies. Methadone costs about 6 cents a day. And because methadone also has an impact on the treatment as prevention cascade, the proportion of people who achieve every element of the HIV treatment cascade is higher in people who inject drugs who get on methadone versus those who do not, or opioid agonist therapy, including buprenorphine. And so the mathematical modeling says that both treatment as prevention and adequate coverage with opioid agonist therapies are important, but the most cost-effective way to get the most bang for your buck is by doing this, and it's a way to treat two conditions, or at least engage two conditions all at once. When we started the project in Kyrgyzstan, this was the trajectory. Kyrgyzstan was one of the places that was doing really quite well in scaling up opioid agonist therapies. They only have methadone there currently. And then what happened since 2018, there's been a sort of a precipitous hemorrhage in the programs. And so one of the questions is why is this not working the way that it's anticipated to work? And so part of the exploration around this was to really, once again, take a look at the sort of the evidence-based strategies, at least that we have to prevent HIV transmission in people who inject drugs. The two that are probably going to provide the most bang for your buck is getting adequate coverage with opioid agonist therapies and HIV and treatment as prevention, which are synergistic with each other. Syringe services programs are there. They're not adequately scaled to need as well, so that would be another thing. And then PrEP is only available for about 100 people. They're all MSM, and no person who injects drug has received any medication yet. So that will be part of the wave of the future. But given the fact that many people are not diagnosed and they're not on antiretroviral therapy, that was one of the goals, to be able to do this work. We chose a framework that we thought was right for this particular setting. This was the EPIS framework. Like I said, there's a bunch of them out there. The most important thing is choosing a really good one and sticking to it. You don't have to get, every single detail right. Sometimes you have to combine them, as I said before. And we did a fair amount of exploration, which I'll walk you through, and some of the preparation, and then we did some work with implementation as well. But I will say that you have both the inner context, which are those factors that are happening at the clinic level and at the patient level. Then there's the outer context, which is the healthcare system and the funders. You've got bridging factors, which are oftentimes these partnerships that occur, in our case, the academic institutions. So our outer context was our stakeholders at UNDP, which is the global fund agency that provides those services, the US CDC, the Republican Narcology Center. Narcology may not be a term that you recognize, but those are the addiction treatment experts. And I will say that if you try to type that onto your computer, it sort of autocorrects it to necrologist. So I don't like to think of them as the same, but that will happen to you if you try to do this work. The bridging factors were NGOs, active implementers, such as AFU, AIDS Foundation East West, and my university. And then the innovation factors was, how do you sort of think about the OAT delivery? And this was a real challenge that we had in terms of doing our work. And then at the inner context was going to be the actual staff members who took care of the patients and the patients themselves. What we decided to do was to try to come up with an implementation strategy. And we used a bundle of tools, and it's not required that one uses all of these, but there's a lot of things that are within this NIATEX model that have been mostly used for addiction treatment. We're now using it for HIV scale-up, HIV treatment and prevention scale-up. But the NIATEX model is a bundle of implementation tools, and one of the key elements is expert facilitation, and it's mostly built upon quality process improvements. It has a number of things that allow you to do it faster, better, and cheaper. We use a technique called nominal group technique. A lot of times when you're trying to explore, I see people doing these long life history or in-depth qualitative interviews, and they're really good and they're important, but the analysis oftentimes takes a long time. And I like to be able to walk out of a meeting and say, okay, these are the things that we probably need to focus on most, and I'll show you an example of that. And then flow charting. What does it look like for the provider in terms of each step of what they do and what they sort of request? You can imagine that that if you've got 15 different steps, that's going to be really onerous, and the clinicians are not going to be able to take care of as many patients as quickly and as effectively as they might otherwise do that work. And the 5 principles of NIATEX are to really understand and involve the customer. That oftentimes includes a walkthrough. What does it look like for patients? What does it look like for clinicians? To fix the key problems. And if you identify barriers within that nominal group technique that are most important, sometimes you have a list of barriers and say, these are the 14 barriers, and where do you start? Nominal group technique gives you a rank ordering so that you can identify the ones that are at least perceived to be the most important. Nominal group technique is also a more democratic way of doing focus groups. In focus groups, for instance, if this is our focus group, we have one loudmouth at the front of the room who's doing all the talking, and everybody seems to think that that's the expert. I might be the expert on this lecture, but maybe not the expert on implementation. And what nominal group technique does is it gives each person an equal contribution to contributing to the list of barriers, and then equal voting between the members in that group so that everybody has the same sort of contribution to the outcomes. So you fix the key problems. Pick a powerful change leader, and that's really important to identify, who's the roadblock or who might be the roadblock to not getting this done, and seeing if you're able to work through that. Obviously, you should get ideas from outside the organization. And one of the key things here is the facilitation. By sort of guiding people through this PDSA rapid cycle changes, with the changes not taking place over 3 months or 6 months or 12 months, but on monthly changes. I'm going to remove one small piece from this and do it later. What happens at the end of 1 month? Oh, it got better, adopt it. If it doesn't get better, move on to the next thing. So changes oftentimes occur little by little, and you may not know which thing to change first, but you have to start somewhere. Here's an example of our nominal group technique. We just put up these pieces of paper. We've done this online using Zoom with voting and all of these sorts of things. It's really I think of it as a fun exercise. It looks painful by looking at this on paper, but the group really gets into this. They are contributing, and I'll show you some pictures of them actually doing this work. And the question here was, what gets in the way of patients entering OAT? We had a couple of groups doing this. And, and the voting is in the parentheses here, but you can see as these two groups were working in separate parts of the room. And there's some common themes here. There's some sort of logistical issues. It's difficult to get registered. It's difficult to go through and get laboratory tests. It's difficult to sit down and go through withdrawal while you're trying to answer all of these questions. There were a lot of myths and misinformation. Those were common themes that came together. Incredible stigma towards methadone by the providers and the clinicians themselves. And then there was always this concern about by the clinicians, well, people don't come because they're not motivated. They have to be, what is the expression? You have to be you have to hit rock bottom, which is not a concept that I believe. It's kind of like HIV. Do you have to have an opportunistic infection before you get treatment? No, you actually intervene where you can effectively sort of interact with them. When you begin to look at the other set of stakeholders, for example, we then did some of the same work with patients. And one of the things that came out, so the patients were providing the clinicians. The clinicians were complaining about the physicians, and then the physicians were complaining about the patients. And so there was a misalignment in terms of where the barriers were. There was a common theme that there was just too many logistical barriers to get through in order to get treated. So that becomes one of the places to do things. There were real unclear expectations for patients. They thought, okay, well, if I go on to this, I'll be cured in a year, as opposed to this being a chronic medical condition. One of the things that we did was we went back and looked at all the original documents. And the original guidance that came from 2015 said you should get on this medication for a year and you should be fine, which is not really aligned with the chronic disease model. So there were sort of misperceptions that happened with this. And so it gives you some rank ordering in terms of where you might want to start. Here's an example. If you take a look in the upper or the middle area, you have a group of people who are going through and they're doing some brainstorming about what might be getting in the way. Then they're going to that piece of paper in the back and coming up with a list. And then one of the other things that they do as part of this, whenever they're trying to figure out what to do, they do flow charting. What does it look like? And so the physician in the lower left-hand side is making flow charts, and you can see that that's part of the screenshot in the middle. And then one of the things that we sort of recognize is since there was considerable misinformation, both for providers and for patients, at least for the providers, we added to the typical NIATEX model stimulus lectures. So in other words, really addressing information deficits so that information deficits could be passed on to patients. And then we would meet regularly as a multi-level stakeholder. So at these stakeholder meetings, not only did we have the leadership at each of the clinics, but we had the funders as well. So we would have larger stakeholder meetings about every 3 months to sort of look at what's going on, to sort of engage them so that there was a lot of really multi-level feedback to the process. One of the things that we'd like to do is, in terms of understanding the customer, is to sort of try to understand what the expectations are. We met with them all separately. The funders from Global Fund, CDC, et cetera. We made site visits to these various clinics to sort of do a walkthrough. What does it look like? We had other people in the field doing it, but when we would make our site visits, we would sort of be respectful of the people in the field to sort of recognize the work that they're doing. I know if you've got 500 clinics, may not be able to do that, but certainly making those visits, at least places that were expressing that they wanted to either show something well that they were doing, or they were really struggling with things to be able to sort of help things. And then you also pick up some things that were really important. If you take a look at the site visit in the left lower corner, this is the way that you go and get methadone. So you have to go to a place, it looks like you're going to a prison. The nurse is protected. There's a plexiglass thing there, which is reasonable, I think, for COVID. But there's no way that there's going to be a connection between the provider and the patient, because they've got this sort of these bars and things like that on the wall, for giving care. And you can imagine that if that's what it looks like, that's the way that the program is going to be perceived. So, a picture can paint 1,000 words, if you will, and sort of talking through some of those things. Now, they do have regulations that methadone has to be behind some kind of, barred, the room has got to be barred, but that doesn't necessarily mean that that's how you have to deliver it. It means that that's where they're storing it. So, and it has to be in a safe and all those other sorts of things. So allowing people to rethink different ways to do that. And part of the collaborative learning, where the folks come together and sort of present, what they're doing, we call them 5x5s. It's the what did you do? How did you do it? What was your baseline? What were your results? Did you adopt it? And so one of the things that you have as part of these collaborative learning is when people show what works, it actually opens up the ideas for change projects for other sites so that they can begin to learn. And one of the things that we've learned as part of our implementation work is collaborative learning, which is really endorsed by the Institute for Healthcare Innovation, is really an important part. I'll talk a little bit about how collaborative learning can actually sort of jettison your scale-up of evidence-based practices. The other thing that's part of collaborative learning is you have to do some team-building exercises. These seem silly, but designing airplanes and throwing them and seeing how far they go and measuring it. So teaching people that measurement is a real issue. That you have to measure how many new patients that you get in, as opposed to saying, yeah, I think I had a few more here and a few more there and they left and stuff like that. But really to sort of, concepts. Team leading in terms of handing over things and figuring out how fast you can pass a ball around and sort of coming up with ideas, moving the people around and stuff like that. That was all part of it, just to really show that it's the process by which you do it. You design your airplane, you throw it, it goes 7 feet, you redesign it, you put an extra curve on the paper and you do it. And it's really sort of giving real-world examples that are fun, perhaps, as opposed to sort of didactic. I mean, you're probably dying in your seat having to listen through all the time, when this would be a lot more fun if it was probably an interactive session. And the NIATEX model has really been demonstrated to work all along the opioid treatment cascade through these change studies. But one of the other things that we do as part of the stimulus lecture is we use their data. I mean, sometimes, you go in and you say, well, in Mozambique, we did this thing and it was really great and it worked. And somebody who's nearby in Namibia or in Ukraine says, yeah, but that's Mozambique, that's not us. And so the extent to which you can use the sort of the local data, so they had a big database on their OAT and we analyzed it and we found some pretty important things. And that is that actually the dose of medication mattered. And so getting people onto a higher dose of medication, which was really not written into their guidelines. Their guidelines said 60 milligrams, but you can see that the retention levels are significantly better, not only at 6 months, but at 3 years, if patients get on sort of an optimal dose of treatment. We also looked at this same database and we found that there was a sort of a large proportion of people who did not get linked to care after prison. Kyrgyzstan is progressive in that it actually provides methadone in prison. It's only one of 9 countries in the world that does this. And so only 21% of people got linked after release. And you can see once again that the dosing made a difference, but only 12% were on sort of the optimal dose. So these became change projects that they could say, oh, let's try to really optimize treatment dosages. There was a lot of resistance to that, but they sort of used their own data. There was collaborative learning. They shared. One prison would do that, and they would actually get their patients to stay and get linked. That actually resulted in them not hemorrhaging their patients off the treatment. And that was one of the most successful things that they did, was getting patients on adequate doses before they left prison. Some of the change projects that got put in place, remember, every place gets to do their own thing, which is one of the nice things. And we all sort of know in implementation that things don't happen equally and at the same time. You oftentimes will have your innovators and those are the people who will take the risks and they'll go and do things and they'll, make some changes and they'll get some benefit. And then you've got your sort of early adopters, which will then say, oh, this is a good idea, let's move on it. Then you've got the late adopters, and then I don't like to use the word laggards, but the people who are never going to do anything. And you have to recognize that. But that's one of the reasons why with implementation, it's not like just a one-year process. People have to come together, they have to learn together. But some of the things that they did in all of the settings was they focused on getting patients on more reasonable doses of medication, not only in the prisons and in the community. They sort of focused on getting patients off standby lists, sort of saying that we don't really have a reason to have a standby list. We have this quota, but there's no reason why we can't do more. I mean, the patient to clinician ratio was really quite low. And then they were sort of spending a lot of time on getting people's urines completely negative, but that's because there was some amphetamine use, and the methadone's not going to work for that. They actually improved their HIV testing. They got 100% of their patients with an opioid agonist therapy treated, and I will tell you that by the end of the study, 100% of their patients were virally suppressed. So that was one of the places where they felt like they could do something about that, and it's basically by getting patients on higher doses, and it sort of stabilized them in a better way. And then they did some fairly good work on the transition from prisons to communities. They also took some lessons. We analyzed the data and what was happening before we started doing a lot of this work, and this was in the early COVID era. And one of the things that COVID does is COVID was a disruptor. It's a disruptor in how we do HIV care, but it's also a disruptor for opioid agonist therapies. And it moved people to take-home dosing in order to mitigate community transmission and to protect staff. So for the first time in Kyrgyzstan, patients got take-home dosing. Unfortunately, each bottle of methadone was about this big, so they'd have to come with a backpack in order to get, up to 5 days of medication, which was better than nothing. In Ukraine, we do it with pills, and so it's very easy to give them their medications as take-home dosing. But they were walking out with a fair amount of medication, and what you can see that happens here is that they didn't really add a lot of new patients during that time, but they sort of flattened out the dropout rate, which was really helpful. So you can see that this sort of flattens out. So that was a learning lesson. So it wasn't that they actually increased the census, but they actually did so without losing more patients. And they did this by take-home dosing. And so that was one of the key lessons learned. So that was something that they began to implement more broadly and adopt. And then one of the things that they were concerned about was whether or not if you gave patients take-home dosing, would they die? That is, would they overdose? And the mortality rate actually decreased because they didn't miss days, they didn't relapse, they didn't overdose, they didn't do a number of other things. So it actually reduced the demands on patients. And that was a hard concept because opioid agonist treatment is about strict control usually, and I think we're learning some important lessons that that's not the case. What I will say in this one short time period, which was a year, OAT increased in the city of Bishkek, and it actually continued to drop elsewhere in the country. So this sort of work, collaborative learning, did actually have an impact in the city. Some of the things that worked best were the prison to community linkages, enhanced dosing strategies, take-home dosing, et cetera. And they, in a couple of the clinics, basically did a quick start. They had a checklist of everything that they had to have done beforehand that they did not end up getting done, in a reasonable amount of time. And then there were some bridging factors. One of the things that happened is that because the stakeholders who were funding this were there, they were actually very excited about the work. They decided to continue providing some funding for this. The Republican Narcology Center changed its protocols so that so that they actually now have take-home dosing as part of that, and they've actually increased the dose, and they actually ask us to help with that. So that is a change that's happening at a structural level. So the things that you do on a per-site basis can have an impact whenever there's a whole group of clinicians, or in this case clinicians, who come together and really support these changes because they saw them happen with their eyes. And then the preliminary data from this ended up us getting an R01 to do work in 3 other countries in Central Asia. So, it actually does play a sort of important role in that there was some recognition that something like this may work. I know we're really running out of time. I was going to say a few things about Ukraine just primarily because in recognition for all the horrible and atrocious things that are happening there. We've been working there since 2004. I'm not going to go into all the slides, but I will say that disruptors, that is changes in the way that the policies that were driven by NIATEX and COVID-19 really resulted in markedly level rates of scale up. These are using interrupted time series, but you can just see it at face value. And one of the things that we did here also was these stimulus lectures and these weekly coaching. We've done this through the war, and I will say that it's an interesting thing having a collaborative learning environment. And remember, not everybody collaborates, so we've got measures of collaboration that we've been looking at. But one of the things that you can see here is we created latent class analyses of the 26 different oblasts throughout the country to decide, who were these 3 phenotypes of chief narcologists, if you will. There were the engaged collaborators who showed up at everything, who came to meetings, who ended up sort of having more change projects that were successful, a number of these other sorts of things. We had a risk taker group, and these were the people, I think, in a natural environment when you don't have implementation, these are the people who are the cowboys and the cowgirls who are going to do something different anyway, and they sort of represent a group of individuals who are going to do something no matter what. So it's kind of letting it happen with very little sort of input. And then the delayed adopters, I did not want to use Rogers' Diffusion of Innovation and call them laggards. That's not a very nice thing to call anybody, except for my kids sometimes. Anyway, so just recognize that not all sites implement equally, but if you sort of take a look at sort of scale up after Order 200 changed, the engaged collaborator did so at a much higher rate, significantly higher rate. And then when you begin to take a look, so there's 2 elements of scaling up. You have to, this is actually new admissions. The other part is retention. They need to not drop out. So in other words, so you can get your scale up. And what you see as a shift here is that the risk takers were more willing to take patients in, but they also lost them at a faster rate. And it's because they did not shore up their systems and sustain the previous changes. And so they're really good at what they're doing, but they're just not quite as good as the engaged collaborators in this learning environment. We've been doing this as part of the war. What's happened is we've increased take-home dosing to a larger proportion. 93% of the patients are on take-home dosing. And you can see that on February the 24th, the patients lost about 800 or so patients. Right after that, clinics were closed down, places were bombed. It was really quite atrocious. We kept up weekly meetings with these clinicians because there was a huge amount of anxiety about where medication was coming from, how to move. I could spend hours talking about what happened. But one of the things that you can see is because they had learned from these previous disruptions and took those lessons alongside the work that they were doing, they were able to not miss a beat. And you can see they went right back up and started scaling up, and so that the scale up is continuing to go very well. And these are some of our Zoom calls that we hold every week, where we've got a couple of pages. We have 26 different people who are sort of on these calls to really bring up what's working well, what's not working well, what's working in some regions, and what to think about as we move forward, with some occasional like lectures. And so if I could just end on this note before there's any questions, to say Slava Ukraini, just because my heart and my thoughts are with them during these last 6 months, but perilous last couple of days. Questions, comments, tomatoes? I duck pretty quickly. Sindhu, did you want to have, I'm going to move out of this light a little bit so that I can actually see you. If you could just tell me your name real quick and where you are.
My name is Teresa Allegrini. I'm from the San Antonio AIDS Foundation in San Antonio, Texas. So I come from an academic background. I'm actually a Yale alumna. And then I went into public health and now run an AIDS organization. So this is fascinating because we're constantly being bombarded with the local university wanting to partner with us.
Huh?
And I, as an academic, am yes, let's do it. We want to do the research. My staff are like, whoa, what's in it for us? Because usually there's no money for staff. We might get money to cover the cost of the medication or something like that, but not for staff. I still think it's important to do. How would you recommend we work with the university to get them to see, like getting us involved at the beginning instead of them just coming to us and telling us, okay, you're going to do this thing that we tell you to do, and then give us at a conference and we might put your name on the bottom of it.
Yeah, that's a really important and legitimate question. And I have to tell you that even when we're doing implementation research, there's always the manna from heaven. But I will say that, when people are reviewing grants, including myself, as I often will say, well, you're asking people to do stuff, but are you really supporting them in any way? One of the things that, that you can potentially do is just say, we would love to partner with you. What you're doing is really important. What we would like to be able to do is, before you design and submit your grant, we would love to have some involvement in terms of some of the research questions. Are these questions that are important for our organization? They may be really quite important for the population that they're trying to work on. Is this okay? And so it's to really be able to say that we really want to be able to do that. It will be much more effective. I think if you can sort of meet with them in advance, the problem is that you have probably 7 different PIs who are all coming to you.
Yeah, it's usually about a week before the grant's due.
Yeah, and I mean, one of the things that you could say is we'd love to sign this, but if there's a center at the institution, there may not be. At our institution, we have a Center for Interdisciplinary Research on AIDS, and we vet everything there through the Community Action Board in order to move it through. We also have a peer review process, and one of the questions that we ask is, to what extent has the community been involved? And then I think that, for people who are writing grants, it's really good to actually say in your preliminary studies that we've met with the stakeholders. I have to tell you, every time I write a grant, I say, we've met with them. This is what they prioritize. And I'll give you like a recent example. We were working in Peru, and I had this great idea that I wanted to jump on PrEP. And they said, we've got a real problem. We're losing patients out of treatment. And they said, what might work? And they said, we put in this thing, we've asked everybody to decentralize. And I said, this lends itself to implementation. So their stakeholders, the people in their community, actually drove those questions. They also drove the things that worried us about implementation, and that is the providers didn't want to give up their patients. So, it actually changed the research question. So I think to the extent to which you can, sort of begin that process, it's important. And I think that's true for wherever you are, for sure. You have some ideas about that?
No, I have another question.
Okay. Did I answer that question? Yeah.
Hi, Alexandra Dokomani from McGill University in Clinician Scientist. I have 2 questions, actually. When you do the grouping, I saw that you had the providers grouping and then the patients grouping. And when you work with multiple clinics in the same area, like what's better, or do you do sometimes both, like within a clinic, patients and providers discussing about their local reality,
Yep.
or always grouping patients on one side and providers on one side?
So by virtue of the fact that we had the head doctor from each clinic coming together, we were getting the head doctors, and we did that as a group when we pulled together. We're doing another study where we're doing an implementation trial in rural settings in West Virginia, for example. And we do the nominal group technique for each individual clinic because if you're in an urban area or a semi-urban area, the issues, the barriers may be very different. So it depends on what the research question is and how I'm organizing the group. So for instance, the trial that I'm doing there is a cluster randomized trial where everybody's activated at once and they're moving forward. In a stepped wedge trial, which is what we're doing, the barriers may change over time, and so we will do that at the site level. So it depends on my trial design. I didn't even talk about trials, but I could have, and so I think about each one of them differently. So I don't have a set formula for that. One of the things that will happen, like in those groups, like some people will say, one of the things that we ask is, well, the top 3 things were this. Does this make sense to you? And then we'll get providers say, none of that makes sense for my clinic. And then we might do something individual there. Whereas people will sort of nod their head and say, I hadn't really thought about this. That does make sense. So we get that clarification as part of the nominal group technique. And I've got a video where I teach nominal group technique, or you may have done it before. There's a ton of different ways to do it. Ashley Hageman has a couple of different methods of rapid cycle triangulation of stuff. There's some really nice stuff out there, and I think the most important thing is to get really comfortable at what you do so that you can do it, efficiently. But you're right, the question may differ depending on what your sites look like, for sure. And in Ukraine, it's the wild, wild east or west, whichever way you think about it. Other questions, comments?
Maybe just one
Yeah.
Your stimulus lecture, did you adopt a specific format for that? Is it like videos, short videos, or?
So the stimulus lecture is completely new. I mean, none of these sorts of implementation strategies we're writing up the paper now on this. But it's the idea that when you're doing something, whatever it is that you're trying to implement, there are major deficits in the knowledge base. So a lot of times with collaborative learning, people will come to, like when I'm doing work in Ukraine and Kyrgyzstan, they are not at the cutting edge of all of the sort of the changes like the buprenorphine, the injectables. They're not really there. And so a lot of times it requires sort of updating the information, or there may be studies of what I call reduced demands on patients where giving them higher doses and take-home dosing very quickly will work. And so we'll present some of the data, we'll get them to reflect on it. A lot of times they're saying, oh, that doesn't really work well here. And then one or two of the cowboys or cowgirls will do it. And then they'll report back. And then that starts to shift it. So, you know, even if you can touch base with one or two people who are ready to take that risk, the risk takers, then those people will then sort of move it out, and the early adopters will begin to do that. So it's a strategy. The other thing that I didn't mention, and I haven't figured out how to write it up, but I use something called nudge theory. So when I've got a collaborative environment, I think about who's likely to be most receptive to it, and I will prime them by having sort of a personal conversation with them. So then they might bring it up so that it doesn't look like the Ivy League professor is walking in and, you know, and pushing something. So there's a little bit of nudge theory that often happens with collaborative learning, not necessarily with other implementation, though.
Is it like champion? Do you try to select like champion, or?
So in each setting, it's good if you can find a champion. What's important is that the champion is not just somebody who will do something, but who is respected by others. So one of the things, so we've developed this collaboration scale that looks at people who do that, but as part of that, we have an additional piece of that, with like, you know, who do you look to for, you know, respect and stuff like that. So it not only needs to be somebody who's willing to be the cowboy, if you will, but somebody who other people really care about. And what's been interesting to me is that the people that I think of when I watch these people interact, and I go out to dinner with them, and, you know, I'm not very good at drinking vodka, but I sit and I pretend like I'm drinking vodka with them. And the people that you think are driving that are not always the same ones, because they pick up their phone and they talk to each other privately. So, you know, we'll say things like, we do these surveys like, you know, gosh, it must be tough during war, you know, who have you reached out to get some advice? And it's some of these quiet ones. So what we think of as a champion is not always a champion. There's a respect piece that I don't think we often measure. Other questions, comments? These are the diehards here. Yes. All right, I think you all have a few minutes before the 1 o'clock session, and like I said, I will be happy to share my slides with anyone. I will let the organizers know that they can, you all can have them. And then for those of you who might want some of these other implementation lectures, I have a training grant for implementation science, and we have a ton of recorded videos and stuff like that, and lectures and stuff like that. And you all are, I can make any of those things accessible to you. I believe in an open access world. Thank you all so much. I appreciate y'all sticking around.